meeting today, we have a packed evening as usual. So, the first session will be a postgraduate session, which will have a panel discussion followed by a journal scan. And subsequently, the CME part will have an interesting lecture followed by another panel discussion. So, to carry this postgraduate session forward, I would request a more chairperson, Dr. P. Ganesh, who is also the president, to give a welcome address and to initiate the proceedings as well. Thank you.
Our secretary said we have a very packed session. I request each of you to probably stick to the time so that we can finish on time. So I request now to get the panelists on stage. Madhusurya, Aditya Kumar, Stanley Medical College, Stephen KMC, Anil Kumar Chimili from Meenakshi, Farhan, come on. I request Arun to kindly take over and connect with you. Arun is a consultant in Apollo Hospitals, very dedicated to gastro teaching. So I think you'll have a very fruitful session.
Dear friends, it's really a great pleasure for me to be in this wonderful gathering in our society meeting TNSG. And I would like to thank our chairperson, Dr. Ganeshan sir, and all the delegates, all the senior consultants for being here. And I would also like to welcome all the panelists, all 5 panelists from various institutions who are being here to join in this discussion about acute liver failure. See, it's nothing but a complex puzzle, a critical challenge. See, outline about this acute liver failure to talk before to take on the discussion for the next 45 to 50 minutes. What are the various areas you are going to cover? One is mainly because what is the various definitions you are going to use? What is the various etiological factor? We will start with the case scenario and followed by how are you going to approach a patient once a patient is landing up with evidence of this kind of presentation, and once how are you going to recognize the complication, how are you going to tackle investigations and management protocol, and when are you going to refer the patient for transplant. That's very important to look into the criteria. So straight away we will go to a case scenario. Ray, this 25 years old women who presented to us with history of basic GI symptoms along with mild right upper quadrant pain, and she had been healthy few days before, followed by she went to recently to Uttarakhand and she had bungee jumping, followed by she had a sprain, she had a injury in the foot, followed by she went for native medications, and the pain reasonably subsided with the medication, followed by within a span of 1 to 2 days, the patient came to the emergency OP with evidence of mild to moderate distress, and the vitals were hemodynamic instability was being there. So heart rate is slightly in the higher range, and respiratory rate is also in the higher range, and there is a white PP when saturation is going almost around 95, and the patient when examination showed evidence of mild tenderness in right hypochondrium, along with there will be evidence of jaundice, clear icterus is there. So in this background, what is the most likely evidence of the clinical presentation? I would like to put this question to Dr. Madhu. So the patient had evidence of jaundice, worsening of symptoms within 2 days with hemodynamic instability in the background of recent history of travel. All these things, what would be the most likely etiology you would like to think? What is the most likely cause? What's the presentation?
Sir, I would like to think viral etiologies first, sir.
Okay.
As there is a history of travel and patient is a
Okay. So
in
since the
India,
patient
it's
had
the
history of
most
travel,
common.
okay. Apart from that, what are the etiological events? Since the patient had jaundice, in this history, what are the etiological events you can think in terms of?
Sir, other it could be some drug induced or because she has taken over the counter medications for a period of while.
Okay. Could it be because of acute liver failure, or you're just simply tackling a scenario of acute hepatitis? What do you think about that? Aditya.
Good evening, sir. Since in the case scenario, the patient has clear means there is icterus and also there is drowsiness, Then but INR is not that till now, sir. I will suggest only acute hepatitis, sir. Since I
So
have no
possibility of
INR.
acute hepatitis is an higher side, but still we need to look into features of
Lot,
acute liver failure whether the
liver
patient is
failure,
progressing. So what are the various etiology in case we are suspecting acute liver failure? What are the various etiology you will be thinking in terms of?
Sir, since the patient is from India, taking into consideration the patient's nationality, acute viral hepatitis remains still the most common cause, being hepatitis A and hepatitis C. Since in our nation we are using lots of herbal medications, and since India is also the hub of tuberculosis, drug-induced liver injury (ATD) being the first possibility, followed
But
by
ATT, the patient has not taken any history. But based upon this
CAM
picture,
intake
it
is there,
might be
sir.
because of complementary CAM and other things, along with hepatitis picture and over-the-counter medications like acetaminophen because of history of trauma. And in the childbearing age, even though if not signifying in the history, we need to look for features of any fatty liver changes in pregnancy or anything else which is happening. And followed by consecutively in a span of time, we have done the blood investigation, which shows very high enzymatic elevation, gone almost in thousands, and alkaline phosphatase is high, and I am now going for severe coagulopathy with creatinine in the range of 1.1, with evidence of your metabolic acidosis mild. So what do you think in this parameter? So the patient is going for worsening of changes that stick onto the diagnosis of acute liver failure. So basically, when you want to look into the diagnosis, what is the basic definition for acute liver failure? In Indian scenario, multiple papers, more than 50 definitions are there for acute liver failure based upon your inasal. First, we need to look into Indian National Society guidelines, what they are saying, what is the time duration. So what do you mean by acute liver failure? What is the time duration? They have been looking into that. Anyone?
Sir, acute liver failure defined.
Farhan, you can come.
It is defined as acute
So
liver
as per
injury.
INASL, you need to stick on to the guidelines. As per INASL statement, what is the definition they will be looking into that?
It is defined as acute liver injury presenting as encephalopathy with coagulopathy, jaundice within a period of 4 weeks.
In the background of a normal
In
liver.
normal,
So
yes.
you need to consider in the duration of 4 weeks, because most of the guidelines they'll be sticking on to the guide, for example, 8 weeks, 12 weeks, and all those things. For example, Trey et al. They've been mentioning the guidelines for 8 weeks. And Ograde is mentioning guidelines up to 12 weeks. ASLD coming with the guidelines almost up to 26 weeks of duration. And our INASL, why? What is the reason? Can anyone able to point it out? What is the reason we are sticking into 4 weeks? Any of the postgraduates?
Yes, the most common etiology, depending on the etiology, the duration. Because in Indian scenario, the most common etiology is hepatitis.
So almost.
Yes, sir. Here, the most common etiology is viral hepatitis and
No, not only based upon the etiology. In our Indian scenario, around 80 to 90% of the population will be landing up with this kind of, in earlier presentation will be. So that's why we need to look. Most of the acute liver failure worsening events will happen within first 4 weeks. So the crucial time we need to take into account rather than thinking for more than 8 weeks of duration in our Indian scenario. That's why our INASL goes with guidelines of 8 weeks, even though most of the most of the other societies not sticking on to that. Okay, and based upon that, how are you going to classify? Can you able to guess it out? How are you going to classify that?
Acute liver failures are classified into hyperacute, acute, and subacute. Sir, hyperacute means time to jaundice will be less.
What is the necessity for us to classify this? Is there any role? So what's the role?
Yes, sir. Because hyperacute and acute liver failure will have higher prognosis, deterioration rate, but it will it is higher incidence of cerebral edema, sir. But it will recover by itself also, sir. Subacute liver failure will progress slowly, but it has higher mortality rate.
So can you give me some example for hyperacute liver failure scenarios? Anyone?
Acetaminophen poisoning will present as hyperacute, sir.
Okay. How frequently you're coming across acetaminophen poisoning in Indian scenario to land up with evidence of acute liver failure? Or you coming across in your routine practice, how frequently you came across with acetaminophen induced ALF?
No, sir, it's very less.
Are you getting some cases in pediatrics? Why in pediatrics it's more common? Can any of the postgraduates can answer? Even though if the patient is landing up with evidence of acute liver failure in background of paracetamol poisoning. Why means pediatric dosage will be entirely different, because there will be evidence of suspension, tablet, and all these various formulation will be there, and drops will be there. So most of the patients, sometimes if you're going to give 5 ml, the patient will be delivering almost around 500 milligrams of the dose. That will be toxic and lethal for most of the babies. So You need to counsel how much is the drops, what is this. This is very, very important because I came across with multiple scenarios when I was in post pediatrics that will be manning up with evidence of acetaminophen induced worsening of events. But luckily, we are not experiencing much of ALF, but worsening of events or GI symptoms, other things will be there. So you should remember that always the dosage guidelines, you need to stick on that too in pediatric population for that. And why we need to categorize this is because subacute, most of the patient we need to go for liver transplant. In hyperacute, if you're going to think in terms of hepatitis E, you can manage conservatively, and most of the time your own reasonable improvement will be there, and hyperacute presentation. So hyperacute will be always looking into good prognostic factors, and acute and fulminant will be looking into a subacute like a presentation. Subacute most of the time will be having worse prognosis. We need to proceed for 80 to 90% of the cases for liver transplant. That's very, very important. We need to look into that. And this is why, so subacute will be worse prognosis. And etiological factors, what will be the differentiating factors in etiology in Indian and Western scenario, any of the postgraduates?
Sir, in Western scenario, paracetamol poisoning, acetaminophen is more common. Whereas coming to India, viral hepatitis is more common, followed by...
Among viral hepatitis, which hepatitis will be more common?
Hepatitis E is more common, followed by B. E is 35%.
Hepatitis E, if you're thinking in terms, it will be more common in pregnant females. You are well known about that. How many percentage of the population you're coming across for hepatitis E to land with evidence of acute liver failure? Around 40 to 50% of the population may land with evidence of acute liver failure, because in an Indian scenario, HIV is the first possibility. Apart from HIV can also happen, but it's still less. But in adult population, HIV will be in the higher side rather than in pediatric population, because as the age progresses, hepatitis A virus will have worsening of events to go for evidence of ALF. That's we should not forget. And apart from that, for example, if you are thinking in terms of drug-induced liver injury, the common scenario in India, the second most common etiological factor in India, can you answer, Madhu? So what's the percentage of population may land up with evidence of ALF with your ATT?
So 30 to 40%.
So in case, apart from that, what are the second etiological factor in drug you can consider to land up with evidence of ALF? No, anti-epileptic will be slightly in the lowest side, around 3% of the population. But second will be your complement, your alternative medication. So around 12% of the population will be in the range of CAM. This you should not forget. And your anti-epileptics and other molecules and antibiotics and other things and all will still be the lower line, and DAPs and all will be still in the lower line. Even though there are chances for these kind of patients to land up with evidence of acute liver failure, we should not forget. Okay, so this is what the various etiological factors, starting from your infective pathology, your drug-induced, your vascular. So what are the reversible causes? So once you're going to treat the patient for ALF, what are the reversible causes? You need to look into that. Reversible causes.
Budd-Chiari syndrome.
Acute Budd-Chiari, okay. So once you're going to improve the hepatic venous outflow tract obstruction, there is a possibility for the patient to improve. Apart from that,
Ischemic liver injury.
Ischemic liver injury and...
So your B viruses. B virus, in case if the patient is going to land with evidence of acute liver failure, what will the prognosis?
It has almost 75% mortality without liver transplant.
Yes, that's very important. So B virus, even though if the patient is going to land with ALF, the chances of progression for mortality will be in the higher side. And apart from the reversible causes will be HIV as well as HIV and all those things. Apart from, you should not forget these basic pointers like your Wilson's, autoimmune hepatitis, if you're going to consider the patient on steroids, as well as drug-induced, if you're going to manage it promptly, you need to consider that. And this is what, and very importantly, see, if a patient comes to our OP with jaundice in the background of NCAF-like presentation, will you jump into the conclusion this is mainly because of ALF? No. So what are the various mimics you need to consider? What are the various mimics? All jaundice, does it mean you want to consider liver pathology, or you want to look for some of the mimics which is progressing to that?
So we can also take into consideration other infective pathologies like leptospirosis, scrub typhus, malaria, dengue. All these are very common in our nation.
So non-hepatotrophic viruses, how many percentage would be more common to land up with evidence of liver failure? Or 40 to 50% of the population, non-A, non-E. Okay. Apart from that, other etiological things like your, what are the other mimics? Your pancreatitis, for example, the patient may have this kind of presentation. Your cholangitis may have this kind of presentation. So what are the things? Your meningitic focus may have this kind of presentation. Severe septicemia. Among the infection, which in Indian scenario, as per your latest position statement, in as what they mentioned, in Indian scenario, which infection among non-hepatotrophic will be predisposing to this ALF?
Malaria, sir.
Yeah, malaria, approximately around 50% of the population may land up with evidence of malaria. So what is the treatment of choice you're going to choose once you're going to decide with malaria at the background of ALF?
Artesunate, sir.
Artesunate. So dose, you need to mention the dose 2.4 milligrams per kg and need to maintain for a duration along with doxycycline you need to consider if you want to tackle with malaria and other things. So look for the predominant etiology, assess the patient as a whole. That's very important to look into this mimic. So always you should assess mimic. Any simple pointers to remember. If in case if you are going to land up with evidence of 3 major indicators, do you have any indicators to assess this patient might be having a mimic rather than this patient is mainly because of hepatotrophic virus? I will tell you 3 major pointer. One is acute kidney injury. If the patients have acute kidney injury at presentation, most of the time the patient may have leptospira, other possibility, rather than you are going to think in terms of ALF, mainly because of your hepatotrophic pathology. And second one is thrombocytopenia. Thrombocytopenia usually in dengue ALF, around, even though dengue ALF will be less common in our scenario, pediatric population will be coming across more. And apart from the initial presentation itself, if the INR, if it is not going to have major derangement, normal or only mildly prolonged. So, which means the possibility for hepatotrophic virus to progress to ALF will be in the lowest set. That's we should not forget. And etiological workup, very simple, all the basic virology screening, HSV, CMV, all those things based upon theoretical markers, but toxicology screen you need to do most of the time when you're going to suspect. But how far we are going to establish in India, so the paracetamol dose, the paracetamol acetaminophen dose, toxicology screening and Wilson screening, all these things in etiological workup, huge battery of workup is there, but clinical assessment of the patient as a whole is very important. We cannot put the patient for all line of investigations, which is very, very difficult to establish in Indian scenario. So which will be the best thing? We need to focus, we need to assess a proper history, and then we need to do a proper etiological workup. Prognostication is very important based upon that. So once the patient is going to have a liver transplant, within 1 year, almost around 80% of the patient will be having a good survival rate. That's very important. And you need to be in state of heart centers. That's very, very important rather than going up. So when are you going to shift? What is the criteria for severe acute liver injury? Is there any criteria for that? So to shift the patient from your OP basis to the patient, the tertiary care center, is there any acute liver injury? Is there any criteria to look into that? Severe acute liver injury. Do you have any definition for that? There is a AIMS protocol being there for that. Do you have any guidelines? Any one of the postgraduates? See.
Sir, if there is coagulopathy or which is not improving, sir, plus there is encephalopathy which is increasing, the grades of encephalopathy is deteriorating, sir, plus if there is heart rate, the patient is in tachycardia, sir.
Leukocytosis, fever, leukocytosis along with NCAF and INR and bilirubin changes. These are all the parameters. Why means all the patient will not land up with evidence of NCAF. These changes itself we need to pick up early to determine this patient to be transferred to the higher center. That's the definition for severe acute liver injury being mentioned most of the guidelines. So you need to see that. And King's, what is the role of King's? Various criteria are there to assess the patient prognostication as well as transplant guidelines. Your Clichy criteria, King's, your so many models are there. So first thing is, what is the beneficial role of your King's criteria? Why King's criteria is more beneficial and not beneficial? If you want to look into the, can you able to point out what is the disadvantage of this King's criteria?
So one thing is, it doesn't take the dynamic parameters, sir. And also it has the low negative predictive values, sir. Also the...
So, yeah, fine. Tell me. The main thing is the low negative predictive value. Will be high specificity, but the sensitivity for your Kings will be low. Why means the Kings initially been coined within a duration of almost around 14 years of preparation for almost around 500 to 600 patients. They have been surveyed, and then they have been looking into 2 major parameters. One is your clinical parameters and one is your etiological parameters. But they couldn't able to establish a proper survival guidelines. That's very, very important, because even if 3 or more parameters, if it tends to be positive, 80% of the patient is going to die because of this acute liver failure. And if 3 or more parameters, even though if it tends to be negative, still 30% is going to die because of this acute liver failure. That is why KCC you cannot take into account for most of the patient when you are going to judge whether the patient deserves treatment or not. For to change that, is there any other scoring system in your routine practice you can consider that? It is a prospective study.
Alfred scoring system
Okay, what
we
is
can
it,
consider.
Alfred?
It is actually having 5 parameters taking into consideration. The
No,
patient's,
ideally it is 4 parameters.
the bilirubin being more than 15, serum ammonia being more than 123, INR, and create also, and if the HE also, and if
Why we need to take ammonia into consideration? What is the normal ammonia levels to test? And once a patient is going for evidence of liver failure, what are the various cutoffs of ammonia you are going to take to reserve the patient for your CRRT or plasma exchange, all those things? What is the cutoff you are going to choose?
If the patient's serum arterial ammonia level is persistently more than 123 mole per liter, then we need to take the patient, consider taking the patient for CRRT.
If 2 arterial samples, if it is more than 150, then it's a consideration. Or if 1 arterial sample, if it is going to be more than 200, then it's a consideration. And in alpha scoring, what is the highest score? Worsening of severity. If the patient is going for 5 to 6, means that alpha severity will be in the higher side than the patient. So why it is so important? Day 1, day 2, almost dynamic changes of your parameters you can assess. That's how we can able to decide whether the patient deserves transplant or not. So with this, we can able to transfer the patient to IR center. We can able to prognosticate. And very interesting scenario, how are you going to manage this kind of patients in your intensive care unit? So once you're going, it's a teamwork. Your hepatologist, your ICU team, anesthetic team, as well as your surgeon. In case, for example, acute bud carry, there might be a role, and intervention radiologist, there might be a role. All those para things is a multidisciplinary approach. You need to look into that. And first thing, what is the first thing you need to decide whether the patient deserves intensive care, and what is the first line of management you are going to choose for a patient who landed up with evidence of acute liver failure, and you can be able to establish a proper diagnosis. What is the first thing you can do?
First, we need to find the exact, if it is possible, we need to find the exact cause for the acute liver failure.
Is it possible for you to find the exact cause for all the patients who landed up with evidence of ALF? How far it is not common? So all the patients with ALF, or how many percent of the population you cannot able to diagnose a cause? How many percentage?
More than half of the percentage.
Around 30 to 40% of the population will be very difficult for you to diagnose. So in that kind of background, we are going to progress. And so first we need to identify the etiological triggers based upon your paracetamol, Wilson's, Amanita, Felon, so many other etiological causes. So identify the cause, treat the patient, very important. If the drug induced, affirm the drug, stop the drug. And apart from that, hepatotrophic viruses B and other things, you can easily, you can start the patient with antiviral support and all those things. And autoimmune hepatitis is very important. You should not consider, always you should consider when you're going to tackle, because steroidal management is very important when you're going to tackle with evidence of autoimmune hepatitis. And apart from that, so next line, you are going to establish a cause, you are going to initiate the first line of treatment, but the hemodynamic instability is still going on, the patient scenario is worsening, and what are you going to do? So what in case if you're having one molecule to choose, everybody in a routine ICU practice, we are going to use this one molecule. What's the first line of molecule you're going to choose?
N-acetylcysteine.
So N-acetylcysteine, what is the various indications for N-acetylcysteine in acute liver failure? All the patients you are going to use NAC, or only for selected patients you are going to use NAC in a routine scenario?
Definitely for paracetamol poisoning induced acute liver failure, we will definitely use it. And since it is having an antioxidant effect, we can still consider using NAC for other conditions also. Even if we are
okay, what is going to happen in paracetamol poisoning? What's the mechanism of action of NAC? It's going to replenish your glutathione stores. Can anyone able to point out the dosage for IV as well as oral formulation for NAC in paracetamol poisoning?
So for IV, sir, which
Make it fast.
IV, sir, we give the loading dose of 150 mg per kg body weight, sir, for 1 hour, followed by 50 mg per kg body weight for next 4 hours, followed by 100 mg per kg body weight for next 16 hours, sir.
So totally you need to target around 300 milligrams per kg over a duration of 21 hours. That is a target. So is there any adverse event for N-acetylcysteine? Any facial flushing, hypertension, whether you're coming across any adverse event when you're going to use your NAC? How far? In case if you're going to use, whether you experience in that? There might be case reports of hypertension being reported for few patients, but even though we are not looking into much of scenarios, since most of the patients in critical care we will be looking into, but even then, flushing, hypertension, still more patients are being there to report. But fortunately, we are having only one molecule to consider, so we need to start the patient. Oral means the dosage will be, you start with, what is the dose we are considering for oral?
Sir, 140 mg per kg, followed stat dose, followed by 70 mg per kg
For 17
fourth
doses.
interval for 17 doses.
So once you are going to initiate the patient, so our target, we need to use your various prognostication scoring system, Alfred Model, Kings and all those things, and look for condition for liver degeneration and look for optimization for transplant. And in intensive care, the intensivist role is coming into an account. So we need to target our central nervous system. That's very important. Your respiratory, your CVS, your hematological parameters and your infective parameters, metabolic parameters, nutrition factors, all these basic things we should not forget when you're going to tackle a patient in intensive care. First thing is very important to address your cerebral perfusion. So what are you going to do? How are you going to recognize ICT? What are the various methodology to recognize ICT?
Sir, there are non-invasive methods to measure and invasive methods. And non-invasive methods, we can measure optic nerve sheath diameter, sir.
So
And
what
if
is
it
that
is,
optic nerve sheath diameter? What is going to, you are going to use a linear probe, okay? With that, what is the cutoff you are going to take into account?
sir,
If it
if
is
it
going
is
to
more
be,
than 4.5 to 5.5 mm,
okay.
when it below the retina, 3
When it
mm
is how
below
many
the
millimeters
retina,
below the retina levels?
3
3
mm
millimeters.
below the retina,
So
sir.
what is the definition for cerebral
It,
perfusion pressure? CPP.
sir,
Low cerebral perfusion pressure means what is the definition you are going to take into account?
if a prolonged period for more than 2 hours, if the ICP is more than 25 or cerebral perfusion pressure is less than 40
What is the
mmHg,
target
sir.
cerebral perfusion pressure normal for any person?
So 60 to
60 to
80.
80. So in background of if the patient is having cerebral hyperperfusion, so what is that cerebral perfusion pressure? How do you calculate?
Sir, MAP minus intracranial pressure, sir.
So what is it map? What is the target map?
Target MAP is 60 to 75, sir.
So 60 to 80 you need to maintain for the target map. Why map is so important to target? Because for the circulatory assessment, once the map is going down, you need to maintain the patient with your vasopressors and other things. So we need to tackle the patient, head and elevation, neutral position, maintain the patient in dark room, maintain the assess the ICT, look for evidence of cerebral perfusion. Okay, so you are diagnosing the patient with evidence of cerebral edema. So are you going to do CT for all? Ideally, pre-transplant CT is a must, and if it's feasible, if the patient you need to do a CT, and in case if you are having focal neurological deficit, you need to do a CT. And I'm having a scenario where these molecules, lactose, LOLA, hyperventilation, hypothermia, GI decontamination. What's your opinion in that? Are you going to use that routinely
No, sir.
in the background of ALF?
No, sir. No role.
Why? If lactose, if you're not going to consider much, means why?
Sir, it will cause it will further worsen the dehydration status and will
So
decrease
worsening
the
of abdominal distension, all those things may happen
blood.
with your lactose. So you are supposed to be very cautious even then. But oral lactose, no major role. But lactose enemas, there are some papers to call the beneficial role. Gut decontamination, is there any role? No major role. What about Lola? What is the dose you are going to choose? What is the precautions you need to see?
5 grams.
No, 5 grams in 100 ml namasaline, you need to maintain the dose of 8 hourly. If you want, you can give. But
You should
Lola,
not
what
give
are the
an
precautions?
acute
If the
kidney
patient is
injury.
having acute kidney injury, so
Maybe we
how
can-
many percentage of population in routine practice will be landing up with evidence of acute kidney injury when you are tackling a patient with acute liver failure? So how many percentage?
Almost 40 to more than 50%
So more than
have,
40
sir.
to 80% of the population will be having evidence of acute kidney injury. So neurological damage will be in the range of 40 to 50. Acute kidney injury will be in the range of 40 to 80, and infective parameters will be more than 50. So all these things you should remember. So addressing the patient as a whole is very important to tackle the patient effectively in an intensive care setup. Apart from that, no major roles with all the other things. What is needed? What is the thing which is we are supposed to look for? So you need to look for cardiovascular stability, acidosis, acute kidney injury, your coagulopathy, your sodium levels, your glucose levels, and correct your infection. And if the patient has low systemic vascular resistance, you need to target that. That's important. For example, in this case scenario, within a span of time, you are going to see the serum sodium of almost around 131. So what are you going to do with INR more than 4? Creatinine is 1. So coagulopathy is persisting. What is the target sodium you are going to choose? How are you going to manage in the background of hyponatremia?
Sir, in this case, the sodium is 131, sir. That our target sodium should be 145 to 150, sir. And for this, we can use 3% sodium chloride, sir.
So once you are going, what's the dose of 3% NaCl? So are you going to use 3% NaCl or mannitol? So what is the cutoff
Right.
to decide that?
Sir, right now, serum sodium is low, sir. That I will go for the
So if you are
3%
going to
sodium.
give 3% NaCl, what is the dose you are going to use?
Sir, it should be corrected, sir. The
Farhan, Farhan.
Not more than 12 milliequivalents per day.
No, that is okay, man. What is the dose you are going to use?
Uh,
How frequently, how long you are going to give? What's the dose you are going to choose?
3% NaCl.
No, there are various papers. You need to give 100 ml of 100 ml of normal saline. You are going to use 3%, 100 ml of solution, or in 200 ml of solution. What are the things you are going to use? You need to give at a dose of almost around 4 hours of duration. That's very important. And apart from that, when you are going to use your sodium, you need to be very cautious. You should not go more correction, because there is a chances for the patient go for hypernatremia with evidence of CNS bleed, intracellular hemorrhage. There is a possibility for the patient to land out. So You should not go, the cutoff is less than 12 millimoles in 24 hours or 16 millimoles in 48 hours. That's a cutoff. You should look into that, and we need to monitor the sodium. That's very important. And various molecules. If you are going to use mannitol, what are the conditions? What are the criteria you need to see for mannitol? Farhan.
Like AK should not be there, sir. While the patient
No, I
is
couldn't
being
able to hear you.
AK should not be there, sir. When patient is being considered for mannitol.
Okay, then. So you need to look for serum osmolality. The
Serum
cutoff
osmolality.
should not be going more than 320. That's very, very important. What is the dose of mannitol you are going to choose?
So 0.5 mg per kg.
So not mg, it's grams per
So
kg.
grams,
So
grams.
0.5 grams, and there are some papers to look even up to 2 grams per kg you can consider your mannitol, because what is the mechanism of action of mannitol in ALF, in background of cerebral edema?
Acts as osmotic diuresis, so it removes the water and it helps and does not cause help to recover from the astrocyte swelling, sir. So it helps in decreasing the pressure of the brain
So
parenchyma.
fine. So in this background, if the patient at 24 hours still the bilirubin is going high, INR is worsening, grade 4 NCAF. So is there any role for FFP for a patient in the background of ALF if INR is worsening? So are you going to give non-bleeder? Are you going to give this patient with FFP?
No, so in case if the patient is not bleeder, sir, and if you're not planning an invasive procedure, then there is no role of FFP.
So what is is there any role for FFP? What is the criteria you're going to choose? You're going to use, what are the various parameters? Are you going to consider INR, or you're going to use something else apart from that? What is the role of TEG and ROTAM to be considered over here? What is POCUS?
Point of care ultrasound.
The point
sir.
of care ultrasound, if you're going to use, suppose if you're planning for any catheterization, any arterial cath, any peripheral venous cath, if you're going for that, what is the cutoff INR you're going to choose in the background of ALF to prior to give all these things?
1.5, sir.
So I suppose if you're planning for any major intervention procedure like any cardiac cath and all those things, if you're placing in background of ILF, so what is the cutoff you're going to choose?
INR of 2 less than
2. So INR should be maintained in the range of 2. That's very important. Apart from that, so what are the various adverse events? If you are going to use too much of FFP, what is going to happen? The patient may have worsening of events like your TACO. What is TACO?
transfusion associated cardiac
And
cell.
TACO and PRALI and all those things, there might be evidence of patient to go for worsening of your alkalosis. So that might be a possibility. So all these things you need to look into that before giving FFP. Most of the time, if the patient is non-bleeder, no role of FFP. Ideally, you need to wait and watch unless if you're not going to do any intervention procedures. Coagulopathy, so apart from when you're going to intubate, when you're going to ventilate the patient.
When patient is going to grade 3 to 4 hepatic encephalopathy, sir.
So grade 3, 4 HE, so okay, it's a criteria to look into that, it's a proven. But grade 2 also some papers are there to look for the beneficial role. Because grade 2, what is the problem with if you're going to ventilate the patient early? What is the risk of infections will be there? And how far?
Chest infections, sir, because of asthma.
So, yes. So in case if the patient is going to land with ventilator associated complications, what is the duration usually it will be taking around for a patient with
3 to
ALF?
5 days. Sir.
3 to 5 days. So even though most of the ALF scenario, the patient will be landing within 3 to 5 days, it's better to, even for grade 2 NCAF, in order to maintain the CPP adequately, it's better to intubate the patient rather than considering for a prolonged duration of time. This is what is important. And respiratory issues, how will you tackle the respiratory complications? So what is a PEEP, and once you're going to intubate, what is a PEEP and tidal volume, all those things you're going to set?
Low tidal volume of 6 to 8. With
Are you
low
going to do
PEEP, sir.
hyperventilation? No.
Yeah,
No. So in case, what is the PCO2 level you need to target?
30 to 40, sir.
So 35 to 40, that's ideal PCO2 what's the recommendation. There is no major role for prophylactic hyperventilation. For respiratory events, what are the 4 things you need to follow? Suppose, what are the major sedative factors you need to consider? Because the patient, if not sedated properly, the patient are worsening. Are you going to use propofol?
Yes, sir.
So blood pressure
Yes,
is
sir.
more than 100.
No, we need to see whether the systolic BP, if it is more than 100, then we can use propofol. What are the molecules we can try apart from that? What is the role of atracurium?
Sir, if a ventilator asynchrony is there,
So then we can consider your this one. What is the role of barbiturates?
so if a patient is planned for liver transplantation, then
And what are the other molecules like frequently you'll be using, but you're not supposed to use much? No major recommendations.
fentanyl has no role.
Fentanyl, no major role. Bidaz has no major role. So
no,
these
sir.
2 things you should be very careful when you're going to look into that. And cardiovascular instability. So always you need to target your MAP. Target MAP should be more than 60. That's very important. And if the MAP for renal complications, if the patient is having evidence of acute kidney injury, what is the target MAP you need to choose?
Greater than 75. sir.
75 should be the target. That's very important. So if the MAP is not maintaining, so you need to start the patient on vasopressors. So because it's a vasodilatory state and systemic vasodilatation will be there, so the patient will be having, since the patient is having evidence of ALF, so how are you going to address this patient with your vasoconstrictor like your NORAD? NORAD, what is the dose you are going to choose?
We will be giving starting at a dose of 0.05 microgram per kg per minute, and we will try up titrate if not responding at 0.025 microgram per kg per minute. Maximum dose of 0.2 to 0.3 microgram per kg per
Anything
minute.
else along with your NORAD you can add? Madhu?
Vasopressin also we can
So
consider.
what's the dose? Vasopressin, if you're going to use, what's the dose?
1 to 2 mil.
1 to 2 units per hour. So that's you can consider. If the patient not responding in the background of adrenal cortical insufficiency, you can give steroids. But methylpred, you can give a shot, but you need to be very cautious because most of the time the patient will be having worsening of ALF. So the patient may have fulminant septic focus can precipitate. So you need to be very careful before you're going to use the patient on steroids. For renal dysfunction, so what is the thing? So you are going to choose your continuous renal replacement therapy. So acute kidney injury, what is the definition for acute kidney injury?
Rise in baseline serum creatinine greater than or equal to point.
Fargan, huh? Fargan, please answer. For what is the definition for acute kidney injury? Give it to Fargan.
Sir, raise in creatinine level 0.3 grams. 0.3 grams or more than 50% in last recorded creatinine, or a decrease in urinary output less than 6 ml in the last 6 hours.
So you are going to use your CRRT. So in this background, you are going to consider CRRT for all.
Sir, CRRT can be implemented when there is
What are the criteria to choose?
criteria. CRRT can be implemented when there is grade 3, grade 4 encephalopathy, along with that when there is severe acute injury or when.
So only things in renal dysfunction, the CRRT indications will be in background of cerebral, your worsening of encephalopathy accepted because hyperammonemia. As I already discussed, the ammonia, if it is going to be more than 200, it's ideal parameter to consider. Apart from that, in the background of your your renal injury, all those parameters you can add. Apart from in the background of CRRT, you can remove this metabolic acidosis, hyperlactatemia. All these pointers you need to address when you're going to use your CRRT. Okay, so that's important. And infection, very common. What are the commonest infections you're coming across in the ICU scenario?
Pulmonary infections are most
No.
common.
So how many percentage? Or also when you're talking about something, you need to talk about the percentages first. So gram negative means how many percentage? What's the most common events? In case of fungal, if the patient is going to land up, what is the most common percentage? How many percentage the patient will be having?
Around 30 to 40% patients will land
Usually
up with
30 to
fungal
40% in bacterial source. Among bacteria, gram negative will be more common. In fungus,
Candida will be more.
Canada, around 25% of the possibility to be having landing up with evidence of. And so what is the various baseline antibiotic you are going to choose in that?
Gram negative coverage can be given, sir.
You are not clear.
Gram negative coverage can be given like.
So what's the antibiotic choice?
Sir, any peptides can be given or along any.
Piperacillin tazobactam with cicoplanin along with antifungal. What else you can consider?
Echinocandidates can be considered.
Oriconazole. Oriconazole can be considered. So once the nutrition is very important for most of the patients in the catabolic state, they need to take care of the nutrition. So what is the ideal nutrition target of protein as well as your calorie intake should be
Around
maintained?
30 to 35 kilocalories per kg can be considered with the protein intake of 1.5 to 2 grams.
Okay, so early enteral feeding, NG tube, NG placement, do you think it's recommended much?
No, sir, it causes gag reflex and there is increased chances of increase in ICT. It is not recommended.
So no major recommendation. So there is another case scenario I would like to state here: plasma exchange versus CRRT in this female who had evidence of jaundice. Briefly go through the scenario. The ammonia which has gone almost around 165 and creat has almost gone up to 2. And the patient diagnosed as ALF due to HEV with grade 2 NCAF and jaundice and other presentation. So within a span of time, the patient had worsening of events with NCAF and MAP is almost maintained only 60 even with adequate fluid replacement. So in this background, why do you want to consider your CRRT?
Sir,
Anyone?
patient is having renal failure, one, and another is ammonia is more than 150.
Yes.
Persistently rising ammonia also.
Okay. So this is, suppose if you are going to use your CRRT, briefly we want to discuss. So what is the role of CRRT? What is the role of plasma exchange? All these things is still very, very difficult areas to address most of the time. And what is the role of your extracorporeal liver assist devices? Still, even though we are reading most of the time, will be very difficult area to attain that interest. So if you're going for CRRT, what is the ideal various things? What are the various infiltration rate, or all those things? You please tell me. CRT principles.
In CRRT, mostly this ammonia can be removed. Whereas coming to plasma exchange, we can correct the coagulopathy. Also can be
No,
corrected. So
mainly in
always
CRRT, you are going to look for water soluble toxins. That's very, very important. For plasma exchange, you are going to look for predominantly large molecular weight compounds like your albumin bound toxins. That's we are going to remove. For example, your bilirubin and all those things. So, when albumin bound compounds, you are going to remove by your plex. So, that's why CRRT to be initial. So, in case if you are going to use your CRRT, what is the ideal duration you are going to choose? So, you can give at least around 3 to 5 days of cycle for plasma exchange.
minimum 3 cycles.
So, okay, in case of CRRF, what is a infusion pattern you are going to choose? Continuous veno-venous, arteriovenous, or veno-venous hemodiafiltration? What is the things you are going to choose? We are going to, in the background of ARF with renal injury with acidosis.
Hemodiafiltration is
What is the
better,
dose?
sir.
What's the rate of infusion?
Sir, 25 to 35, sir.
So, almost around 35 ml per kg per hour you are going to choose, and you need to maintain a target ammonia should be less than 100. Okay, so that's very, very important. And once you're going to use that, the patient will be having some extent to have a minimal response, followed by within the span of 2 days, the patient being subjected to plasma exchange. And once you're going to subject the patient to plasma exchange, in this scenario, the patient have more improvement of clinical scenario. So iron is still coming down, ammonia is still coming down, the native liver is improving, no major transplant considering HEV background. So combination always may be superior in this kind of backgrounds like your ammonia control, your cytokine toxicity removal. So because immunomodulation, all those things based upon your CRT and plex you are going to consider, and mainly in plex you are going to tackle with your various immunomodulation techniques and all those things, and coagulopathy fixation and survival benefit will be reasonably good prior to bridge to liver transplant you need to consider. This is another case scenario. Our TNSG is very interested in this area, rodenticide poisoning, and very frequently we are coming across rodenticide. Briefly, you should know about the pathophysiological concepts about your rodenticide poisoning, even though it's out of area for discussion. 1 or 2 minutes we can spend in that. Apart from, and what are the various compounds in that? Any one of the PGs?
Sir, it can be anticoagulant or metal phosphates. Thallium can be there. Strychnine can be there.
So, okay, in our paste, what is the commonest thing will be the
Sir,
yellow phosphorus? Okay, so what is the lethal dose of yellow phosphorus? Any postgraduates can come out.
More than 10 grams.
More than?
More than 10 grams.
More than 10 grams is lethal. Just go through that. I think it's 60. Okay. So apart from that, in case of rodenticide, what is the various pathophysiological, what is the major mechanism of action of that rodenticide poisoning to predispose to ALF? For example, in the background of your yellow phosphorus as a paste.
Sir, yellow phosphorus will
It's a what component? What's the major area is going to get involved?
It combines with HCl to form a phosphine which is highly toxic, sir.
Okay.
And it will
To
inhibit the
which area it's toxic? To which organelle it tends to be more toxic? It's a protoplasmic. Protoplasmic and mitochondrial injury is going to get happen. That's very, very important. And what are the other compounds are there? What is warfarin and superwarfarin compounds
Sir,
in rodenticide poisoning? So briefly, see, you should remember why I want to like to, even though it's not in the area of discussion, rodenticide poisoning in Indian scenario, very common. Why? Is there any criteria to assess? No. Even KCC not fitting into the criteria, your Clichy not fitting into the criteria, no major criteria to assess. The rodenticide poisoning in our Tamilnadu will be having a major setback for ALF. That's very, very important. We need to look into that because easily available of your paste. So, very importantly, you need to look into that, whether the patient, what kind of consumption they be made, and aluminium, so many other things are there. Various compounds are there for this rodenticide. One is aluminium phosphate, zinc phosphide, your thallium, as well as warfarin and superwarfarin compounds. All these things you need to see before you are going to look into because each and everything will be having various mechanism of action. For example, if you are going to look for thallium, means you will be having cardiac involvement. Predominantly, cardiac toxicity will be more common rather than hepato. So, all these pointers you need to see before considering what kind of antidote, what is the antidote you are going to choose, how are you going to manage. All these pointers is very important. That's very when you are going to look into rodenticide poisoning. So, for example, in this background, the patient had rodenticide poisoning, followed by severe worsening of enzymes, severe metabolic acidosis. The same scenario in the background of minimal ascites, severe ALF, MAP is going to be very low. So, what are you going to do? So your therapeutic plasma exchange along with your plex and CRT you can consider in this kind of background. So that's very, very important as per your various guidelines, your APASL, ASLD, even in INASL as well as a TNSG they have mentioned. So if you are going to use your plex, what is high volume plex?
Sir, when it is more than 1.5 times the plasma volume, that plasma volume will
No,
be.
no, no. I am asking about what do you mean by high volume plex. It's
Yeah.
not 1.5 times. It will be more than
Two
4
to-
times of the plasma volume. High
Ideally,
volume,
we should-
standard volume and low volume. There are 3 categories of a plex. The high volume will be more than 4 times. Okay. What about the standard volume?
1 to 2 times, sir.
Low.
Low volumes are 0.5 times of the.
Okay. So if you are going for a plex, means what is the duration you are going to choose for plex?
At least we should plan plex for 3 sessions, sir.
Okay. Then, so what are the various toxins you are going to eliminate with your plex? Mainly by your albumin-bound toxins, macromolecular toxins, and your ammonia may not be much of role. That's why you need to consider in the background hepatic NCAF, your CRRT-based regimen rather than your plex. But if the patient is having predominant of coagulopathy changes and all those things, you can consider your plex along with the other parameters. So, based upon the regimen, you need to choose a combination therapy, and if the patient not responding, subject the patient for transplant. And before concluding, few points about autoimmune hepatitis. This scenario, young female, same background with mild hepatomegaly and splenomegaly, no major splenomegaly, jaundice to encephalopathy duration in the background of almost around 16 days, and viral markers tends to be negative, and your ammonia tends to be in the higher side, and lactate is in the borderline, and MAP is okay. And in this background, is there any possibility? The enzymes almost gone up to AST and ALT in thousands. What is your likelihood for this kind of patients to land with evidence of autoimmune hepatitis? Stephen.
So, sir, since the routine etiological workup was negative, and since it's a younger female who presents with ALF, we also can take into consideration of autoimmune hepatitis after working up for the autoimmune hepatitis markers, sir. So,
No, usually in autoimmune hepatitis, do you think this much of elevation of liver enzymes? Usually no.
no, sir, it's unexpected usually.
But even though our scenario, we cannot expect with the lab reports alone. Because if you want to rule out autoimmune hepatitis, what is the scoring system you are going to choose in the background of fulminant hepatic failure? What is the scoring you are going to use? Are you going to use simplified scoring?
No, sir.
So, no. So, what is the revised scoring then? See, autoimmune hepatitis, the one important differentiating factor is even if the patient is having cirrhosis or even if the patient is not having cirrhosis in the background, you need to consider for acute liver failure. That is one exceptional pointer. Like your DILI for 4 to 8 weeks of duration, you are considering like this. Autoimmune hepatitis, even in background cirrhosis or without cirrhosis, you are going to consider. But once a patient is landing up with evidence of suspicion of autoimmune and fulminant autoimmune hepatitis in ALF, how are you going to diagnose that? Anyone?
Biopsy maybe.
Biopsy we need to consider.
So biopsy is a main pointer. So if you are going to do your IgG levels, even then if you are going for revised criteria based upon, and even though if you are going for look for your various markers, your ANAs, I mean all those things, if you are going to see, there might be only 40% of the population. So if these markers tends to be negative, the prognosis is still guarded. The prognosis will be very poor for this kind of patient. So you need to be very careful. Doesn't mean that if the markers are negative, the patient is not having findings of AH. So you need to go for histological assessment. So are you going to subject histological assessment for all? Difficult, because ICU setup, ascitic background might be a difficult task. So TGLB. So are you going to subject? No. That's still a doubtful issues. And if you're not going to do a liver biopsy, are you going to use steroid or not?
Yes.
No, so you need to be very cautious before subjecting. So that's why we are telling, if you are having a think of prescription, so there is a plan based upon your ASLD guidelines. If you are going to look into the paper, if your male, if it is going to be more than 15, you can give a short course of steroid, but be careful, the patient may have worsening of infections like other complications. Septic focus may go worsen, and in case if the patient not responding in the span of time, you need to consider the patient for early liver transplant. That is very important. And there are various modalities of presentation of your fulminant autoimmune hepatitis, like chronic disease with spontaneous exacerbation, or acute AAH or ACLD background with any aftermath. For example, once the patient is going for transplant, after that also the patient may land with evidence of your acute fulminant autoimmune hepatitis like presentation. And briefly about your extracorporeal liver assist devices before we are concluding. See, ELAD almost in same, but two things. What is the major components for ELAD? One is your bioartificial, another one is artificial source. What is the things? What are the components in that?
So by artificial means there's hepatocytes also, so which provide both detoxification and the synthetic function.
Yes.
But in artificial, liver just is
Can you
provide
give me some
detoxi-
examples? What is Mars? Mars.
Mars is it is also extra liver assist device, sir, but it provides only detoxification, sir.
So what is it's a, what is the major thing? It's a conventional dialysis process in which you are going to use albumin against dialysis. So what is the rate of infusion for Mars and all those things? It's more of theoretical. We are not going much into the detail, but you should remember what are the various things. One is Mars is there, your Prometheus device is there, so many other things are there. Na? So among them, you should remember what is PAT.
Single pass almond dialysis.
Single pass
So what is the
dialysis.
difference? Are you going to use in that?
Sir, actually single pass almond dialysis is very costly, sir. Once we remove that, again it will not be coming into the dialyzer. So we have to remove albumin. Excess amount of albumin should be removed.
And also when you are going to use your CRT, you should remember that CVVVH, you can remove your solids and ammonia. When you are going to use your hemodiafiltration, you can remove your toxins as well as your ammonia and macrotoxins and microtoxins. CVV, HDH. Apart from that, when you are going for usage for SCUF, slow continuous ultrafiltration, what is the role? No major role. So it will be predominantly removing the solids. So these are all things you should remember when you are looking for the parameters of your plasma exchange or your CRRT or even then extracorporeal liver assist devices. So many things are there. But how far it is successful, still a questionable issue. What is MELS, MELS?
It is a bi-artificial device, sir.
Extracorporeal liver support model. Okay, that's very important. So very important, when not to transplant. When not to transplant.
When patient had irreversible brain injury like absence of brainstem reflexes or more than 3 organ dysfunction or more than 2 vasopressor support is required, or when we think that patient is going to improve, when there is recovery is expected, then we should not transplant.
So severe multi-organ failure, septic background, worsening of sepsis, or in the background of irreversible brain disease. So are you going to label all the patients brain death just like that? There are various criteria to recognize a patient for brain death. You should know what are the major criteria, what are the minor criteria before considering the patient for transplant consideration to be initiated or not. So those things you should not forget. What are the various reflexes you need to see? What are the various investigations you need to see? All these pointers you need to address. And so what are the various, these are all the various guidelines for consideration. So briefly go through that. And the key takeaway is assess the patient as a whole, look for the proper history. If proper history, you can able to identify, treat the history, and NAC for most of the patient, CRRT and PLEX based upon the clinical criteria, and maintain the intravascular homeostasis and all those things, and consider the patient for transplant. With that, I'm happy to rest my presentation. Thank you all for patient listening.
So thank you, Arun. We'll expect questions from students. And is there anything you want to discuss? So, you want to make?
See,
Thank you, sir.
congratulations, Arun. You took us through acute liver failure. I think most of them are probably managed by critical care ICU specialized liver units. But I think most of us should know what to anticipate when you have a patient with acute liver failure. The idea is to anticipate which patient will recover spontaneously with your aggressive medical management so that you don't put them into a liver transplant program unnecessarily, and probably when they are going to improve with medical management, it is very important that you correctly select patients for transplant. Patients with hyperacute liver failure generally tend to improve with probably aggressive medical management. Those who have prolonged jaundice to encephalopathy more than 7 days, these are patients who probably don't do well, and then you should not procrastinate too much in these patients. So probably you need to get the liver unit in touch and then probably see whether they can take over and plan for management. The issue is availability of organs, because this is supra-urgent management in acute liver failure. You don't have cadaveric donors. As in Western countries, it is a problem. In India, probably we are more into rival-related transplant, and then we have no issues. The take-home points will be here that you should identify properly a person who is going into acute liver failure and probably immediately transport them to specialized liver care ICUs, how to manage hypoglycemia, how to manage hyponatremia, how to manage intracranial pressure. Beautifully taken you through all that. Most important thing which we probably did not discuss was sepsis. It's very important that most of these patients are probably immunoperitic and will require antibiotic cover prophylactically, especially when you're putting them on CRRT and those who require intubation. So don't delay intubation in patients who require that. It's very important that you team up with the ICU people and then probably manage these patients. Those patients who require transplant need to be listed for urgent, super urgent transplant. And probably in our setup, we have facility for life related, but if you're waiting for cadaver transplant, these patients do not survive till the transplant is available. And for you, it's required that you need to know everything about plasma exchange because that is the in thing now and it is a bridge to transplant. Patients who are in acute liver failure can be managed with plasma exchange judiciously till you have a liver. So it's very important you know everything about plasma exchange, which you beautifully said. Wonderful session, Arun. Thank you so much.
Thank you very much, sir. Thank you.
A request.
Any comments, sir?
Thank you for all the panelists.
So one thing in rat poisoning, this L-phosphorus is a lipophilic compound. So if you do a plasma exchange, there will be improvement. But then if you don't see improvement, and then if you consider them for an early transplant, all this L-phosphorus which are attached to the fatty unit will be released after the transplant, and you will have the graft failure. So that is one important. And the other infection, he said actually you should do 4 culture bottles, 2 for anaerobic and 2 for aerobic. If you send only one set, it will give a positivity rate of 30%. If you send 2 sets, it will give a 80%. More than 2 sets, there will be incremental culture positivity, but then at least minimum 2 sets you should. And you should always know the local bacteria prevalence pattern. Most of the infection specialists, they will know. Once you get a culture report, then you can modify the antibiotic as per the culture report. And then adults usually the complication is usually not bleeding. They usually die of cerebral edema. That is why he discussed so much of cerebral edema. In children, it is slightly different. If they are very small, below 5 years, before the suture line closure, cerebral the encephalopathy may not be the complication. Then those patients you should consider the other liver failure features for considering liver transplant. Anything else? Anybody want to make a comment? Thank you, Arun. Excellent. You boldly sat there and answered most of the question. Very good. So the next session is journal scan, review of recent publications from India and liver disorders. To present that, I invite Dr. Harrison from Government Kilpauk Medical College.
On publications from India on liver disorders. So totally I will be presenting 12 articles that has been published recently. Mainly it will be covering 6 articles will be covering cirrhosis, 2 will be regarding alcoholic hepatitis, 2 will be regarding viral, and 1 regarding autoimmune, and 1 regarding HCC. So coming to the first article, it is published in American Journal of Gastroenterology on July 2025. This article is regarding the efficacy and safety of carvedilol in cirrhotic patients with new onset uncomplicated ascites without high risk esophageal varices. The trial named as CARVIAS trial. It has been done by Sarain et al. In ILBS. So the aim of the study is to use carvedilol for prevention of ascites related complications. So it is a open label randomized control trial. Patients having uncomplicated new onset varices ascites with no or low risk esophageal varices have been randomized into 2 groups with 52 persons in each group. the group A receiving carvedilol plus standard treatment and group B receiving standard treatment alone. So coming to the results, the primary outcome, which is at 1 year, that is the incidence of complicated ascites at 1 year is the primary outcome which they have studied, in which the group A 38.5% has incidence has occurred in 38.5%. However, in group B, there is 67.3%. I have already told group A is carvedilol plus standard treatment. So it has a p-value of significant 0.03. So the incidence of AKA is also considerably lesser in group A, and better resolution of ascites is also better in group A compared to group B with statistically significant p-values. Coming to the secondary outcome of the study, the number of large volume paracentesis session which the patients had underwent is considerably larger in group B compared to in group A, 26% to 57%, and the CTP score and 1 year mortality, everything has been significantly better in group A compared to group B, and no treatment related serious adverse events have been documented. So based on this, the conclusion has been made that administration of carvedilol in patients with cirrhosis with new onset uncomplicated ascites, even without high risk varices, is safe, and it can prevent further complications and reducing large volume paracentesis and improving survival. Coming to the next article, it's an addition of midodrine to albumin reduces the incidence of complication of large volume paracentesis. It is an RCT comparing midodrine, terlipressin and albumin, published in Hepatology International on July 4, 2025. It has also been conducted by Sarin et al. From ILBS. So the aim is mainly to assess prevention of PICD by addition of vasoconstrictors to albumin during large volume paracentesis. So it is also a single center prospective open label randomized control trial, and cirrhotic patients undergoing large volume paracentesis with refractory ascites are taken into the study, and the sample size is 165, and patients has been divided into 3 groups, group 1, 2 and 3. Group 1 received albumin alone, group 2 received terlipressin with albumin, group 3 received midodrine with albumin. Terlipressin is given at a dose of 1 mg IV bolus at the onset of paracentesis, followed by at 8th hour and 16th hour. And midodrine with albumin is in this group, midodrine is given at a dose of 7.5 mg TDS for 3 days. So the results, the primary endpoints, that is incidence of PICD. There is no statistical difference of incidence of PICD in group, all groups, 14%, 7% and 11%. The p-value of 0.46 is the significant. Coming to the secondary endpoints, here there is slight difference with the addition of midodrine to the large volume paracentesis groups. So the incidence of new onset complications was significantly higher in group 1 and group 2 compared to group 3, that is the midodrine group. And the mean arterial pressure reduction in group 1 and group 2 is higher compared to in group 3 on day 3. So the overall mortality on day 28 was no different between these groups. So the main thing, the incidence of complications can be reduced by addition of midodrine. So the conclusion is the addition of oral midodrine to albumin prevents hypotensive episodes on day 3, thereby reducing the incidence of new onset complications following large volume paracentesis. Without, however, no mortality benefit is there, and PICD reduction benefit is not the same. Next article is tips superior to SIMS in management of refractory variceal bleed in advanced cirrhotic patients. It has been published in Liver International on August 2025. It has been done by in ILBS by Sarin et al. So the aim is comparing TIPS and SIMS in patients with refractory variceal bleed. So this is a single center open label prospective randomized control trial. The population is the cirrhotic patients with refractory esophageal variceal bleed or post EVL ulcer bleed who are not controlled by endoscopic therapy or rebleed after therapies. So the sample size is 41, and randomization is 1:1 block randomization has been done, and TIPS patient is randomized into 20 and 21. The TIPS patients 20 and SIMS group contains 21 patients. Coming to the primary results, the mortality at 6 weeks, the SIMS group has comparatively lesser mortality. TIPS group has comparatively lesser mortality compared to SIMS, with 10 patients death in SIMS group and only 2 patients in TIPS group. Of the SIMS group, 3 persons died due to rebleeding. The TIPS group, the death is not due to rebleeding but due to the progression of liver disease actually. The secondary outcomes, which is the very early bleeding and rebleeding at 6 weeks, all has been is comparatively lesser in TIPS group than in SIMS group. The new onset sepsis, HE, or also new onset sepsis is lesser in TIPS group, and however HE is mildly increased in TIPS group. However, there is no statistical significance. So conclusion, in patients with advanced liver disease with failure to control of bleed or very early rebleed, placement of tips is more effective than placement of SIMS. Coming to the fourth articles. So endoscopic glue injection versus glue plus some radiological investigation, either BRTO or TIPS for preventing gastric variceal bleed. This is also a randomized control trial published in Clinical Gastroenterology and Hepatology Journal. It is conducted in AIIMS. So the aim of the study is to compare the efficacy of glue versus glue plus radiological intervention, either TIPS or BRTO, for secondary prophylaxis of patients with liver cirrhosis with acute gastric variceal bleeding. So it's an open label, parallel group, non-blinded, single-centered RCT. So randomization is a block randomization with each arm containing 45 patients. So the primary outcome, the results is gastric variceal rebleeding rate between the two groups at 1 year has been measured, in which the endoscopic arm, there is 11 patients versus there is only one patient in endoscopic with radiological intervention arm with a statistical significance of 0.04. So secondary outcome, which includes overall or GV gastric variceal bleed related mortality, change in liver function and complication rate associated with procedure at 1 year. The all cause mortality is more in endoscopic arm than in radiation interventional arm, with 12 in EI arm and 7 in RA arm. And gastric variceal rebleeding related mortality is also higher in endoscopic arm compared to in interventional arm of 8 versus 1. So based on this, conclusion has been made that radiological intervention for secondary prophylaxis reduces rebleeding for gastric varices and gastric varices rebleeding related mortality. In the study, esophageal varices patients has been eliminated from the study. Then diagnostic accuracy of spleen dedicated 100 Hz transient elastography to predict high risk esophageal varices. This article has been published in American Journal of Gastroenterology on August 22, 2025. It's done in AIIMS Bhubaneswar. So the aim is, just I already mentioned, to assess the diagnostic performance of splenic stiffness measurement in predicting high risk esophageal varices and clinically significant portal hypertension using a 100 Hz transient elastogrammetry scope. So design, it is a single center prospective cohort study. Patients with cirrhosis have been taken into the study. 116 patients have been analyzed, and the results of the study is splenic stiffness measurement cutoff of 35 kPa is in compensated cirrhosis at a sensitivity of 95.6%, and the area under curve of splenic stiffness measurement is 0.849. However, the liver splenic stiffness measurement alone is 0.68, and if you are combining liver stiffness measurements with platelet, the area under curve is rising to 0.80, and combination of all three has a significant value of 0.86. And so suppose if LSM is compared along with liver stiffness measurement and platelet count, the number of endoscopies which can be spared in SSM group has nearly 44.8% compared to liver stiffness measurement and platelet count, which is 21.5%. The high risk esophageal variceal miss rate is 6.1% in isolated splenic stiffness measurement compared to LSM and platelet count. So in conclusion, SSM alone can accurately predict high risk esophageal varices in cirrhosis. However, in combination, it can give a better results. So regarding ROTEM, this is a comparison of relaxed versus standard cutoff of rotational thromboelastogram for guiding blood products used for invasive procedures in advanced cirrhosis. It's a randomized control trial published in Hepatology International on May 25. So it has been conducted in Department of Hepatology and Liver Transplantation, ILBS. So the aim is to evaluate the safety and efficacy of relaxed ROTEM score versus the standard conventional threshold in which have been used in liver transplantation for prophylactic blood transfusion. This threshold has been tested in other invasive procedures in cirrhotic patients. So the method, it is a prospective open label randomized control trial. The population is patients with advanced cirrhosis undergoing any invasive procedures. The sample size is 1043. The randomization of relaxed ROTEM criteria, the patient included is 524 versus 519. So the intervention which has been given is in standard ROTEM standard group. The fresh frozen plasma is given when extem CT is more than 80, and single donor platelet or 6 random donor platelet is given when extem MCF or FIPTEM MCF is less than 35 or more than or equal to 8 mm, and 5 pooled units of cryo if extem MCF or 5 FES MCF is less than 35 and less than 8. In relaxed, the criteria is little bit reduced, and extem criteria has been extended to 90. In platelet, it has been reduced to 30, and in cryo, it has been reduced to 7. So overall results, the proportion of patients transfused any blood products in standard ROTAM group was 359 of 519 patients, which is approximately 67.8%. However, in relaxed ROTAM group, the patients underwent transfusion is 287 of 524, which is 54.8%. So there is more significant more transfusion in standard ROTAM compared to the relaxed ROTAM group. However, the post-procedural bleeding and complications and 28-day mortality was similar between the two groups. So relaxation of ROTAM cutoff can be done without increased risk of bleeding, thereby reducing the number of transfusions in the patients of cirrhotic liver cirrhosis patient. So coming to our next session, centrifugal technique of plasma exchange and low dose steroids to treat very severe alcoholic hepatitis, a retrospective analysis. It has been published in Indian Journal of Gastroenterology on June 2025. It has been conducted by CMC Vellore. So the aim is to compare 1 year survival of very severe alcoholic hepatitis patients treated with centrifugal plex, membrane plex, or standard medical treatment. So the method is retrospective cohort analysis. The population is very severe alcoholic hepatitis patient, and the total sample is 101 samples. So 30 patients underwent C-plex and 21 patients underwent membrane plex, and 50% underwent standard medical treatment. So to adjust the baseline differences, since it being a retrospective study, to adjust the baseline difference, the propensity scoring matching has been done. And the patients who underwent plex, 3 low volume plex with 1:1 replacement of FFP has been done. So coming to the results, initially comparing centrifuge plex and low dose steroids versus standard medical treatment, the transplant-free survival rate, that is at 1 year, is 52.4% in centrifugal plex versus 16.7% in standard medical treatment. The overall survival from 1 month, 3 months, and 1 year, everything, there is a statistically significance in C-plex group. Comparing C-plex with M-plex, that is centrifuge plex versus membranous plex, the transplant-free survival rate, here also there is a statistically significant difference between the two type of plex also. So the 1 month, 3 month, and 1 year survival is better in centrifuge plex than in membranous plex. Then another analysis has been done in the study, in which propensity matching has been done, and 21 patients from each group with equal baseline difference has been taken, and from this analysis, the difference is also significant and patient undergoing C-plex has significantly better result compared to M-plex. So conclusion, better 1 year transplant-free survival was noted among PS-matched very severe alcoholic hepatitis patient treated with C-plex compared to SMT, standard medical treatment. So the next trial is published in American Journal of Gastroenterology. It has been published in May 2025. So granulocyte colony stimulating factor, whether it improves prednisolone responsiveness and 90-day improved survival in steroid eligible severe alcoholic associated hepatitis patient. So it is a randomized controlled trial conducted in ILBS by Saran et al. So the aim is to study safety and efficacy of combination of granulocyte colony stimulating factor plus prednisolone and G-pred therapy in management of steroid eligible patients with severe alcoholic hepatitis. It is a prospective open label randomized control trial. The population is steroid eligible patient with severe alcoholic hepatitis with MDF of 32 to 90 has been taken. The overall sample is 126, and it has been randomized into 3 groups, group A, B, and C. In A only, the patient received only steroids. Group B received steroid plus GCSF. Group C received only GCSF. So the intervention is being GCSF is given at 150 to 300 mics per day for 7 days, followed by every 3rd day to a maximum of 12 doses in 1 month. And prednisolone is given as 40 mg per day for the first 7 days. Based on Lilly score, if the patient is showing response, steroid has been continued. Coming to the primary results of the endpoint, the 90-day survival. So the 90-day survival in group A is 64.3%, group B is 88.1%, and group C is 78.6%. So compared to prednisolone group, that is group A, Group B has significant results with a significant p-value of 0.03. Coming to the secondary endpoints, 28-day survival rate, there was no benefit difference in 28-day survival between the three groups. Coming to the adverse events, new infections. The group A had 35% infection, group B has 19, and group C has 7% infection. So the infection rate is getting reduced in group B. If low dose steroid with GCSF, the new infection rate is less compared to group A steroid alone. And group C, just GCSF group has better reduction in infection rates. And AKA incidence is also more in group A compared to in group B and group C. And HE incidence is also more in group A compared to group B and group C. So group B overall has a significantly reduced adverse events. And the rehospitalization rate in group A is 59, group B is 14, and group C is 13. In this rehospitalization secondary endpoint also, the group B, that is GCSF plus steroid, has shown a significantly better results. So conclusions, the addition of GCSF to prednisolone improves steroid responsiveness and 90-day survival with fewer infection and new onset complication in patients with severe alcoholic hepatitis. The next study, plasma exchange with corticosteroids as a rescue therapy for severe prolonged cholestasis in acute viral hepatitis. This has been published in Journal of Clinical and Experimental Hepatology. The study has been conducted in PGI. So the aim is to assess the role of plasma exchange with corticosteroids on severe prolonged cholestasis in viral hepatitis. It is a retrospective cohort study. The sample size is 59. The study group population is 44 and the control group they have taken as 15. In the 44, combination of centrifugal plex with corticosteroid has been given. Standard volume plex has been done for these patients and the corticosteroid has been given at a dose of 0.5 mg per kg. So actually the study group has been, the patients are underwent plex when they are not responding to antipruritic medication. These patients has been taken up for the plex. The results, primary outcome, improvement in serum bilirubin and VAS score at 4 weeks have been assessed. The most common etiology which has been observed in the study is HIV being the most common etiology of severe prolonged cholestasis. The percentage reduction in bilirubin between control group and combination group was analyzed at week 1 and week 4. In week 1, the reduction in bilirubin is 43.6% in combination group. However, in control group, it is 37%. At week 4, it is 93.8% and 89.4%. Actually, it's not looking too wide, but however, the statistical significance p-value is significant. The pruritus severity, which is assessed by VAS score, is also showing better results in combination group than in control group. So, plex combined with low-dose oral corticosteroid results in significant improvement in prolonged cholestasis and can be considered as an effective rescue therapy. Coming to the next journal, impact of RAS and predictors of treatment failure following direct antiviral treatment in viral hepatitis C. It's a cohort study published in Journal of Clinical and Experimental Hepatology conducted in PGH Chandigarh. So the aim is to identify reasons for treatment failure in HCV patients treated with DAA and whether there is any impact of RAS in the cases. So the method is patients treatment failure patients in Punjab under the NVHCP program has been taken up in the study, which is approximately 8.4%, which is 4,272 patients have been taken in the study. And of this, 640 patients who have been referred to the hub, that is PGH Chandigarh, they have been assessed for RAS, of which only 314 of the patients RAS can be amplified. So the results based on the analysis which has been done, the clinical predictors for treatment failure based on univariate binary logistic regression analysis, old age, male, gender, urban residency, high APRI, presence of cirrhosis, genotype 3 and poor compliance have been associated with treatment failure. However, based on multivariable analysis, old age, presence of cirrhosis and drug compliance, these three are the main thing which have been associated with treatment failure. And in these logistic regressions, the RAS has not shown any impact in treatment failure cases. And the RAS, the resistant association substitution which has been analyzed in the study is NS5A mutation, 42 mutation have been detected, of which 31 corresponds to RAS and 11 of unknown significance. And NS5B, there are only no mutations have been analyzed. So the patient factor like compliance and presence of cirrhosis predict treatment failure. RAS do not appear to be a primary factor for treatment failure in public health settings. the next article is efficacy, safety, and long-term clinical outcome of low dose versus high dose prednisolone induction in autoimmune hepatitis, a propensity score matched analysis. It has been published in Digestive Disease Science on June 2025. It has been done in AIMS, Delhi. So it is to compare the efficacy of low versus high dose prednisolone, that is less than 20 and more than 20 mg prednisolone induction regimen in patients with autoimmune hepatitis, and their response in biochemical response have been analyzed. So it is a retrospective cohort study. The population is treatment naive autoimmune hepatitis patients. Totally 121 patients have been taken up in the study, 47 receiving low dose and 74 receiving high dose prednisolone, and propensity score matching has been done, and 1:1 ratio of 45 patients in each group has been taken, and analysis has been done. So the primary outcome being the 6 months biochemical response rate with low dose is 62.2% versus high dose is 60%, more or less similar. The secondary outcome being patients with cirrhosis had lower response rate than patients without cirrhosis, and no difference between. However, there is no difference between low and high dose prednisolone in these groups. And the adverse events have been in low dose has been documented to be 27.7%, and high dose it is 43.2% with the. So the incidence of adverse events is lesser in low dose compared to in higher dose, with equal efficacy in biochemical response at 6 months. So low dose less than 20 mg prednisolone induction results in similar biochemical response and clinical outcome compared to high dose regimen in patients with autoimmune hepatitis. Coming to the last journal, so it is a validation of multiplex hypermethylation based blitzes test in detecting hepatocellular carcinoma, a prospective case control study. So it has been published in Journal of Clinical and Experimental Hepatology. It has been done by Institute of Liver Disease and Transplant in Dr. Rela Institute Hospital. So the aim of the study is to evaluate the performance of investigational, that multiplex hypermethylation based HCC screening test in detection of HCC. So it is a prospective case control study. All patients with diagnosed CLD has been taken into the study. The case being CLD with HCC, control being CLD without HCC. The diagnosis of HCC has been made by radiological imaging as the gold standard. So 588 patients have been analyzed, in which 142 patients being the case and 446 being the control. The results being the sensitivity and specificity of the multiplex hypermethylation based HCC screening is 91% sensitive and specificity of 88%, with positive predictive value of 71% and negative predictive value of 97%. Actually, it also identified 57 of 62 patients with AFP negative HCCs. So compared to AFB, it has better predicting in picking up HCC in the early stages. And conclusion, based on the results, it has been concluded that multiplex hypermethylation based HCC screening demonstrates high accuracy for detecting HCC signal. However, further combining it with the AFB, the sensitivity has been increased from 91% to 96%. Thank you.
Thank you. We almost covered a wide range of liver diseases publications. I have only one comment, not with the medical liver disease, GI bleeding. So you compared SEMS with TIPS, but both of them, they compare for the control of bleeding, but both the strategies look at different ways. One is only compresses the esophageal varices and occlude the vein. So when the original etiology for the bleeding and varices is portal hypertension. SEMS doesn't manage portal hypertension. Ideally, what you should do is you should, in all patients, if they have a severe uncontrollable bleeding, you should put a SEMS. And before removing the SEMS, you should do a TIPS. Then it will work more. So the other, any other thing, any PGs, doctors want to make a comment, sir? Anybody, anything? You want to say something?
Thank you, sir.
He's got a point, isn't it?
Yes, sir.
So stenting is only for
temporary measures.
Control of
Bleeding.
massive bleed. Because sometimes you're blind, you just put a stent and come. But should always be followed by
Reduction in portal pressure by TIPS.
portal pressure reduction by TIPS. So maybe comparing these two may be quite biased. That's what we feel.
So how did they measure the elastography of spleen?
Sir, you
Use a US scan?
US. Sorry, sir. Ultrasound guided
Outside
outside only.
US ultrasound ultrasound or?
Normal ultrasound, transabdominal ultrasound.
But then, there is a. If you use a percutaneous ultrasound, then you need to go through the abdominal wall and some fat. Whereas US, you're right on the spleen without any intervening structure. But then this is much easier. This is more invasive. So anyway, so I'll close this session and we'll move on to the next session.
Thank you, sir.
Dr. Perama?
Congratulate all the postgraduate participants in the earlier postgraduate panel discussion, and thank Dr. Arun for conducting the postgraduate panel discussion, and a nice review of literature by Dr. Harrison also. And I thank both the moderators for taking us through the session. Before we move on to the second part of CME on GI oncology, it's my duty to present the secretary report. Be ready in a minute. So taking forward the earlier tradition of conducting the second part, the CME by one of the medical colleges in turn. This time, this CME part has been coordinated from Stanley Medical College under the guidance of Professor Sumati, and I thank her for taking this forward. And I hope to see that the next time around, I will request KMC to take it forward. So that there will be a participation from all the medical colleges in turn. So that makes it much better than just the secretary or the office bearers running it. So going on, again, this the last month has been wonderful again. The stalwarts have got more laurels for our society. Dr. Jayanti was awarded the Lifetime Achievement Award from the Colitis and Crohn's Foundation in India at Cochin last week. And what is also very heartening is that two of our postgraduates from Tamil Nadu, part of the Tamil Nadu ISD, Dr. Shivashish Behra from Madurai Medical College and Dr. Manjunath Hegde from Apollo Chennai, they got Best E-Poster Award in different categories in IBD, the Crohn's and Colitis and Crohn's Foundation at Kochi. And congratulations to both. I hope to see more, we all hope to see more postgraduates winning laurels and awards in the forthcoming meetings also. So the research activity from TNISG, the TNISG Plex study, I congratulate Dr. Alagamai and all the participating centers who have coordinated. And the wonderful news is that it has been accepted for publication in Frontline Gastroenterology. And that has been 2 years of hard work which all the authors and the panelists have put in. And it has found a publication as well. So the next research activity that will be starting now is the Tamil Nadu TNISG HCC study, and I'll request Professor Sumati to take it forward just on how to proceed on this, please.
Actually, the multicentric study on hepatocellular carcinoma through TNISG was decided by the end of the last year. And since we know that HCC being the primary liver tumor with high cancer-related mortality worldwide, as per the WHO registry as well, and most of our patients come with underlying cirrhotics, either due to viruses, with alcohol, or with underlying metabolic liver disease, apart from other metabolic liver disease as well. Hence, we don't have much data from South Indian population, and though the incidence is being around 1.6% in India, so it's around 1.6 per year every year in India, but not much data from our own population. Hence, the decision was taken at the end of the last year. By the end of September 2024, yes, few members from the hepatology group were invited with an online meeting. A pro forma was discussed, and it was focused mainly to focus on the clinical epidemiology data, the tumor burden, the tumor characteristics, and the underlying etiology, along with the surveillance protocol for the cirrhosis, because we don't have strict adherence protocol. Most of our patients do not even turn out for alpha-fetoprotein, which is not available in many centers, along with ultrasound. So it was decided mainly to focus on this, and there are 15 centers where have been included under TNISG, both from public and private sector, including one from JIPMER from Pondicherry. And the initial protocol that was formulated was edited on 2 occasions on subsequent online meetings, and it was formulated finally, and it was circulated through TNISG in January 2025, inviting all the centers to participate with one principal investigator as a primary one, with the help of the other centers as well. And we have advised everyone to get even the IEC approval, because every center should have an IEC approval since being multicentric study once it goes for publication. And it was circulated by our TNISG members to all centers. And in Stanley, we too have applied for IEC and we have obtained in March 2025. And the model has been circulated through TNISG. Awaiting with the response from other centers, actually we decided to conduct the study for 6 months for a period from July to December. But since we do not have much information from other centers regarding IEC approval, we are just awaiting whether we need to extend the study till March, so that if, by the end of next month, if all the other centers can give information on the status of the IEC approval, we can just start uploading, getting data from the day they get IEC approval. And finally, March will be the final deadline to finish the uploading of the data through the Google Forms. And we from Stanley, we have got 32 cases so far and will be uploaded before the end of the time limit. So hoping all the centers to gear up and do the IEC approval and get it informed by the end of the next month. I think the Tamilnadu State IEC chapter will have a better work on HCC, which is a very important topic, because most of our patients come with BC, LC stage C and D, and we are not able to do much even in transplant centers. So thank you for the advice. I think the next month we should get the information from other centers as well. So I think it has been formulated through the mail also. Thank you.
Thank you, ma'am. Probably we'll recirculate the IEC approval that form again through, and we'll follow it up with all the centers. So if all the centers can please submit it to their institutional ethics committee and get their approval in a month's time, it will help us take it forward in the next 6 months. So that by the end of, by the early next year, we should be looking at another publication also. So moving on, in the next key forthcoming meetings, I think the Tamilnadu midterm ISD is scheduled for 11th October at CMC Vellore, and I request all the postgraduates to come forward and submit their abstracts, and they have given the last date as 1st of October. So by the end of this next month, I think you should all be submitting your abstracts, and they have given a structured abstract format and all that, so you can submit it. And please participate in the forthcoming. The next week you will get the registration forms and so forth, and they are working on it right now. Other key forthcoming meetings are the, please note the dates for our annual conference in 2026. That will be from January 30th to 1st of February at Yerkad. It will be held by the Salem team. And the subsequent TNASG endorsed meeting that's coming up in 13th of September at Gastro Mastery by the SRM hospitals, and also a Vellore Gastroenterology Trust meeting that will be coming up in October as well. The Indian Pancreas Club is scheduled for, it's a national level meeting that is scheduled for 4th to 6th of September at Vellore. And our national meeting, the ISG Con, will be from 3rd to 6th of December at Amritsar. So I request and welcome all the new academic trainees who have joined in the last 3 months. I request all of you to become student members of the Tamilnadu ISG. You can download the form from the website, pay the request fees, and then become student members. And also please enroll as members of the National Society. Only then you will be able to participate in all the national level academic activities that the ISG national body conducts. So also please take a minute of yours to scan and enter your email attendance slip on the table that is given below in front of you. And move on to the CME part. As told earlier, this CME has been coordinated from the Stanley Medical College under the guidance of Professor Sumati. I thank her for that. I request the chairpersons, Dr. A. Aravind, Dr. A.R. Venkateshwaran, and Dr. Malarvali to come over and conduct the proceedings, please.
Good evening, one and all. We'll move on to the oncology, GI oncology session. First will be a lecture on targeted therapies in colorectal cancer. I invite Dr. Shankar Srinivasan, Senior Consultant, Department of Medical Oncology, Apollo Hospital.
Part of the CME, I'm going to ask my colleague Dr. Niranjan to talk about 10 minutes. I'm going to be here for next 10 minutes, so that it will be helpful for all the younger faculty to get involved also.
Very good evening, everyone. I'd like to thank the Tamilnadu Medical Gastro Society for giving the opportunity to have a talk on the CRC. So the topic are divided into two parts. One is the concentration on the newer diagnostic approach that as an oncologist we like to have an input from the medical gastro. And the second is the therapeutic relevance, which Dr. Shankar will be talking to you about the next one. So the diagnostic tools, the tumor markers, the staging investigations, what to look in biopsy, part of the Lynch syndrome, and when tissue becomes an issue, what should we do? So these are the outline. So colonoscopy or sigmoidoscopy, that's one of the commonest things. So everybody will look for a colonoscopy. When I have a sigmoid growth, is sigmoidoscopy sufficient? Should I push you for a colonoscopy? When a patient comes in obstruction, the first thing is you get a sigmoid, get a biopsy, find its tumor is obstructing. The surgeon looks for a metastatic workup, doesn't show any metastatic disease, they go for upfront surgery. Still would like you to complete a completion colonoscopy as soon as possible once the patient is fit. That's within 3 months if there is observation, or within the end of treatment, that's 6 months after the completion of adjuvant therapy. So colonoscopy would be a preferred one. So to detect the synchronous always stands ahead of the sigmoidoscopy. And for somebody who is not keen on colonoscopy, as you know, it's CT colonography can be considered as an alternative tool in screening for somebody who hasn't had a complete colonoscopy. And PillCam colon 2 is one more thing which has been USFD approved for screening in CRC, as well as somebody who has had incomplete colonoscopy without any features of obstruction. So coming to the tumor markers, we like to have a CA and a CA 19.9 as a baseline before we initiate any treatment. There can be instances where the tumor is not secreting, so you might still have a normal one, but during the time of recurrence, still there is when a new mutation happens, the non-secretory can become a secretory one. So as a part of staging workup, CT abdomen pelvis is the baseline. So is CT thorax is mandatory or chest X-ray is sufficient? It all depends upon the location of the tumor. Your rectum, mid and lower rectum have a different lymphoidal drainage, and the blood supply is different, so they doesn't go through your superior rectal or the mesenteric, so they do come across a different pathway. So they have high propensity for a lung metastasis when compared to a superior rectal or a colonic tumor. So a CT thorax would be an added tool for a lower rectum or a mid rectal tumor. So what is the role of MRI abdomen? This is quite interesting for suspicious liver mets, obviously, yes. But most important thing as a surgeon who would like to know is, when we deal with an upper rectum, should I go for a neoadjuvant approach or should I go for an upfront surgical resection? So the relationship to the anterior peritoneal reflection is best demarcated by MRI. If my tumor is above the peritoneal reflection, we can take him for upfront surgery rather than subject him for a neoadjuvant radiotherapy or chemotherapy modality. So MRI abdomen would be a preferred tool for somebody with a rectum or a rectosigmoid extending to the rectum. PET-CT is not a mandatory tool. The recommended investigation of PET-CT is when I am dealing with an oligometastatic disease where I see a spot in the liver, what happens to the lung? If it is multiple mets, curative treatment is out of picture. The oligometastatic, still I can go for a curative resection to make sure there is no other site of metastasis. PET plays a major role. But out of logistics, CT thorax, abdomen, pelvis combined, the cost is equal to PET-CT, so people prefer to doing PET-CT. Now, in the biopsy, as a clinician, what are we supposed to look? We need to look for the histology. Not all rectal tumors are adenocarcinoma. We do get googlies like a anorectal melanoma being present, mimicking as a polypedal growth, or a neuroendocrine tumor. Look at the grade. MSL-like histology. These are like high incidence of tumor infiltrating lymphocytes. Crohn's-like histology. Signet ring cell or a mucin secreting tumors point towards underlying Lynch syndrome in a patient who is apparently young. So when you look at these, you can order for MSA testing. Either it can be an IHC based or a PCR based. IHC is readily available. So when to suspect a Lynch syndrome based on the biopsy? Any colorectal diagnosed less than 50 years, patients of synchronous or metachronous disease or other, for example, a gastric one or a cholangio, and a patient now has a CRC, so Lynch associated tumors. When a patient has a MSA high-like histology and patient with first degree relatives or two or more relative with Lynch syndrome, these come under what is called a Bethesda criteria. When somebody fits in, please order Lynch syndrome, the MSA testing to rule out possible Lynch syndrome. So now coming to the history taking part, when to see when a patient walks into a clinic. So this is called 3-to-1 rule. 3 or more relatives, 2 or more successive generation, at least one should be a first degenerative and one should be less than 50 years with Lynn's associated syndrome. So 3 to 1 rule, if it fits in, straight away go in for a germline testing rather than testing the tumor. So this is a simple flow chart. I do an tumor biopsy specimen. I order IHC for 4 proteins: MLH1, PMS2, MSH2, MSH6. Any one of them is lost, then check for the next one. MLH1 and PMS2 are associated with BRAF. So when these MLH1, PMS2 is lost, check for BRAF. If BRAF is mutated, then it is sporadic, it is not germline. So you need not do the blood testing. If BRAF is wild type, there is no mutation, then you order for MLH1 promoter methylation. This is a molecular testing. If that is negative, then it is most likely germline. If that is positive, then it is the MLH promoter is methylated, so it is not through the germline, it is the tumor associated. If there is MSH2, MSH6 loss, straight away go for germline testing. So this is a simple algorithm you can stick in the clinic, wherein when can you start doing an germline testing. So what is the relevance? Why should I know? In a stage 2 disease after resection, if the patient has MSI deficiency, you can avoid giving systemic therapy if there is no high risk features, number 1. Number 2, if it is a stage 2 or 3 colorectal tumors, if the patient has MSI high histology, neoadjuvant immunotherapy has resulted in more than 70% complete response in just 3 doses of treatment. So that's an upcoming data which Dr. Shankar will be presenting in next talk. So these are some therapeutic relevances which have come across. Maybe in colorectal cancer with dostarlimab, we can even avoid doing surgeries if patient has achieved a complete response with immunotherapy. And once we know Lynn syndrome, we need to screen for other tumors, we need to screen the family members. So because of these 3 reasons, we like to do an MSA testing. So now what is the role of NGS? Do we do it for all patients? No. Only in a metastatic setting, we'd like to do. We like to order is NGS in metastatic rather than MSI IHC, because once you cut the tissue for IHC, for one MSH2, MSH3, you waste away all the cells. So if it is NGS, it comes as one panel, 1000 cells are sufficient to detect every single, say around 52 genes. So NGS is a preferred modality in metastatic setting. People say left-sided, anyway they are not going to use cetuximab, so why to do for a right-sided one? We can avoid because right side doesn't respond anyway, but still you can look for NTRK, HER2 and MSI. So please, irrespective of the sidedness of the disease, we order NGS testing. And whether it is comprehensive or hotspot means known mutation only we'll select. So there are n number of new genes that have been detected, so prefer a comprehensive assay rather than a hotspot assay. Now when tissue becomes an issue, what should I do? So when the biopsy is inconclusive, but the PET CT shows locally advanced disease, patient is not willing for a repeat biopsy. That is one of the commonest scenario we encounter. Twice, thrice sigmoidoscopy, patient doesn't want biopsy, what should I do? And when I finish the treatment, when I do a PET CT scan, patient has a metastatic disease, but it's in inaccessible area, what should I do? In those are the scenarios, we do 2 options. One is called CTC, circulating tumor cells, another is ctDNA. To make it into a more practical perspective, we have a scenario wherein a 72-year-old male, case of CA larynx, treated with concurrent chemoradiotherapy in 2013, now found to have a rectal growth. So PET showed an indeterminate lung nodule in the baseline. So then we went ahead with neoadjuvant chemoradiotherapy, surgery and follow-up. During the follow-up, the PET CT showed the lung lesion increased. So he underwent resection of the solitary lung nodule. The post-op HPE did come out to have a lung tumor. So now the only site of disease I have removed. Should I give chemotherapy or should I wait and watch? Because it is metastatic disease. The CEA was normal from the beginning, so I can't go ahead with CEA. So we gave option of observation, systemic therapy. Then we came across something called a CTC. We sent his blood for circulating tumor cells. And since the CTC was detected, we told them that if I don't treat you right now, there is a high likelihood the disease is going to come back. May very well you can undergo the systemic therapy at this juncture. So this is one way where we can do something bit more than wait and watch. Second is a patient of a 70-year-old with bleeding upper rectum. Sigmoidoscopy showed adenocarcinoma. Baseline CA was 21, a secreting tumor, a non-metastatic disease. He underwent upfront surgery. Post-operatively, T3N1 disease, high tumor infiltrating lymphocytes. So MSA testing showed MLH1 loss. Since it is MLH1, we check for BRAF. BRAF was negative, so it is somatic. We didn't do germline testing, and it was negative. So now what we did, we finished the 6 months of treatment. End of treatment, CA became normal. So we kept him on regular follow-up. The CA slowly started to increase around 1 year. We did a PET CT, we found to have a solitary periportal node. So we underwent excision of the periportal node and it came out to be adenocarcinoma. IHC was suggestive of CRC. Again, the post-op CA was normal. Here what we did was, we went ahead to do something better than a CTC. It's called ctDNA. Now we have the baseline tumor. We extracted it, the DNA, we had a KRAS mutation. So we checked in the blood whether this tumor, which has a baseline KRAS, whether there is anything that is detected. The peripheral MRD, it's called cancer track MRD. The ctDNA was negative. So we said we'll wait and watch because the CA was normal. Now he has a secretory tumor. So we will start treating you once your tumor is starting to produce the CA. So upon progression, when the CA started to increase, the PET CT showed new onset mediastinal and retroparietal nodes. Since it was MSI high tumor, we subjected him for an immunotherapy rather than a second line chemo. Within 2 doses, the CA has normalized. He continues to receive with 4th dose of immunotherapy without losing a quality of life. So these are some 2 new advancements from oncological perspective, like a CTC and a ctDNA, in addition to your traditional NGS and IHC, which helps us to tailor treatment accordingly. So other useful scenarios of CTC are in stage 2 Signatra, wherein patient has a high risk disease. Like if you check for Lynch syndrome, you can avoid chemotherapy in stage 2. Similarly, for somebody with non-Lynch syndrome or non-MSI high tumor, can I still avoid is check for ctDNA. If there is nothing in circulation, there is less likely the tumor is going to come back. So you can avoid giving chemotherapy in stage 2. That is one. Second useful scenario is in pancreatic biliary tumor, where tissue is again an issue. Most of the times we feel atypical cells plus, that's it. We are not even convincing our patients to start the treatment. And a recent advancement is ctDNA from bile centrifuge sample. Whenever we are doing a stenting for ERCP, the bile is going to be there. Collect at least a 10 ml of bile, centrifuge it within 7 hours, store it, and then you can try to create pellets from the bile, and then that is going to have a high sensitive because it's there in contact with the tumor. When tissue is not going to become an issue, we can use this bile to do a ctDNA and help us to detect. One such scenario is here, where we had a patient with obstructive jaundice, head of pancreas growth. So patient, we did a ERCP guided stenting. At the same time, we did a biopsy. Unfortunately, we were not able to get the result. Then we did an image guided biopsy, which was again negative. So patient PET CT shows widespread disease. So we sent across a CTC with ICC, immunocytochemistry, and the reports came as probable pancreatic or biliary origin because EpCAM, PAN-CK being positive, CEA-199 is a pancreatic biliary marker that is also positive. Then extra information about a KRAS G12V, which is also a ctDNA. We have extracted the DNA from the circulating cells. We found out KRAS, that is a poor prognostic variant. So with this, we were able to start the patient on adjuvant systemic therapy because it's a tissue became an issue. We are able to finally conclusively say you have a tumor. So medically, legally, we are also safe in starting a patient on a treatment. These are some representative images how the CTC with ICC looks like. So cells in tissue, we stain called IHC. In liquid, when the cells are staying, it's called ICC, immunocytochemistry. This is a representative image for the patient. So I'd like to thank you once again and hand over the stage to Dr. Shankar. Any questions you would like to answer, or if not?
So you are referring this as a liquid biopsy.
Exactly.
It's a liquid biopsy has come of age. That's what I want to tell.
Yes, sir.
So our routine things have gone slightly out of. So liquid biopsy is going to capture the imagination.
Still is going to be there, sir.
Yeah.
But for some reasons where we can't get a biopsy or when tissue is inadequate, still to say to a patient that you have a malignant disease and to start treatment medico-legally, this can help us. Previously, we were waiting and watching to have a bigger disease to be seen radiologically. Now with this, we can start the treatment earlier, sir.
One small doubt. What is the likely cost for ctDNA and CTC? Cost?
CTC are cells.
Cells.
ctDNA is a molecule.
Molecule is a molecule.
Exactly.
What's
sir.
the cost of life?
Sir, the traditional thing which goes to US called Signatra, which is a ctDNA, is somewhere around 2 lakhs. an Indian company called Datar Genetics, Datar Diagnostic. They are doing it at somewhere around CTCs are 50,000 and ctDNA are somewhere around 1 lakh, sir.
1 lakh. So this comes at a cost. Everything
Definitely.
comes at a cost. Yes, sir. Yeah. Just wanted to. Nothing yet. Diagnostic yet.
Some of the insurance.
Thank you, Doctor. It was an excellent. Thank you.
Thank you.
Talking about, I think we are now using more and more ctDNAs and CTCs in our clinic. It is kind of helpful. I mean, sometimes you can cut down the cost by talking to the company and maybe get 20 to 30,000 rupees discounts. Especially most of our patients where we have done will be like young 35, 37-year-old where all of us are stuck with it. So our targeted therapies in colorectal cancer, I will make it fairly brief. What all the targets that we have available right now, which will be like VEGF inhibitors, EGFR, immunotherapy and HER2/neu, BRAF and NTRK. These is the general group of inhibitors targets that we have. The question is, where do we use all these things? I mean, we use it now in multiple scenarios, neoadjuvant setting. Neoadjuvant is anything before any definitive procedure is done to remove the cancer. Adjuvant setting is once the cancer is fully removed, there is no existing disease. And then metastatic setting is obviously extensive disease. So this is the one I think pretty much all of us now know, the locally advanced MMR deficient. Pretty much most of the things are with MSI high or like MMR deficient tumors. Rectal cancer, which is somewhat horrible to have because of the treatment that is involved, will be like chemotherapy, radiation, then chemo, and then surgery. So you're looking at about 1 year. And then post-surgery, they will be either, if they had a bag, that's a problem. If they didn't have a bag, and they will be hitting the bathroom like 30 times a day. Surgeons will say everything will get better. Unfortunately, medical oncologists will have to say, no, it's not going to get better. You better get used to it. So that seems to be our mantra, I think, post-resection half the times. So where do we stand with it? So almost about 10 to 15%, 10% of the rectal cancer will be MSI high. As the stage advances, like early stage tumors, rectal or colon, rectum will be about 10 to 15% will be MSI high. Colon will be about 7 to 8%. Once they are metastatic, our MSI high, the sporadic number comes down. Rectum is about 4 to 5%, colon is about 2 to 3%. So if we find the disease early, probably we'll get a sporadic MSI high tumor. And in these situations, majority of the MSI high tumors, they don't respond to chemotherapy at all. In fact, in the adjuvant setting, a lot of times MSI high tumors, if they get chemotherapy, especially with the 5-fluorouracil based therapy, in fact, the worst prognosis will be worse compared to not taking anything at all. So that is where the immunotherapies came into picture. And the standard article, I think everybody will talk about it probably for another 10 years, will be the dostarlimab for locally advanced rectal cancer. And initially had about 12 patients, subsequently had about 24 patients. The medicine got approval when it reached only 42 patients. I think that's the first time in oncology we had an approval for a drug with only 42 patients being tested. Never in our history we have seen this. It's a single arm, not even phase 3 or not even a comparison arm or anything. The primary endpoint was we will give about 9 cycles, evaluate for residual disease. If there is residual disease, we will give chemo-RT. If there is no residual disease, we will observe. So that was the basic principle, simple principle. Pretty easy to do the trial once you have the patients. The outcomes 12 out of 16, 100% complete CR. The outcome at the end of 42, 100% complete CR. The outcome at the end of 54, 100% complete CR. We have never seen complete CR 100% with any of our oncology setting with the preoperative treatment. So that really led to the approval of dostarlimab in rectal cancer. There was no progressive disease. None of them received radiation. None of them received chemo. None of them went for surgery. So the patients are walking out, treatment is fixed, 6 months, done. And this essentially changed the field of what we will do. I mean, having said that, now the data is up for about 3.5 years. One patient has recurred out of the 54, and this has been repeated more and more. Now the complete response rate has come down to about 96% out of about 480 patients that they have had the data so far. So this is one thing that we always look at. So dostarlimab is now available in India also as of 2 weeks ago. Cost is close to about 9 lakhs or so, which is still fine. I can avoid radiation is about 2 to 3 lakhs. Surgery is probably going to be, God only knows where it's going to be, depending upon. So still, I would take this option if I am MSI high. There are some side effects. Most of them are extremely manageable. Grade 3 and grade 4 are highly unlikely. So this is where we are with the neoadjuvant rectal. The next question is neoadjuvant colon cancer. This is my patient last month. This is in Phoenix when I was there. 58-year-old female. Essentially, she came in with anemia and chest pain. Admitted to the hospital. Triple vessel disease, underwent stent placement because of the anemia, not deemed to be a candidate for CABG. 3 stents were placed and all the usual medications. Cardiologist said, you cannot touch the patient for 6 months. So then she came to us. We saw her there. CT abdomen, mass in the ascending colon, 9 centimeter with pericolic nodes. CT chest was negative. In US, you cannot get a PET scan done because they say like it's not necessary unless you really prove that it's going to change your management. So no PET scan was done. CEA was normal. So what do? We sent the testing. There, any biopsies, any GA tract biopsies will automatically get sent for MSI. We don't even ask for it. If it is not done, it's a quality control deficiency. And she was MSI high. Lynch was negative. So what we did in her was neoadjuvant treatment colon cancer, essentially for high risk stage 2 and stage 3 MSI high patients. This is the trial which came up in the New England Journal. It's again a phase 2 trial. Neoadjuvant nivolumab and ipilimumab for patients who are MSI high, colorectal, stage 2 and 3, not stage 1, 2 and 3. It may be a bit difficult. Essentially, the total number of patients were about close to 300 or so. On all of them are fairly well matched. I can't. Here, if you really look at it, the number of patients with Lynch syndrome are not that many. In fact, the sporadic MSI people did really well compared to the patients who are non-sporadic or Lynch. So when you look at the response, here the people received 2 doses of nivolumab, 1 dose of ipilimumab. So at the end, the treatment was essentially only for 4 weeks. And all of them went for surgery within 6 weeks from the diagnosis. Essentially, complete pathological response was noticed in about 70%. And a major pathological response, that is less than 10% viable tumor, in about 95%. And unable to evaluate was 1. Pretty much everybody responded extremely well. So they continued to follow up post-surgery. Those who had a complete CR did not get any kind of additional treatment. At the end of 3 years now, all of them are doing well except 1 recurrence. So that is where we are. And in my patient, we did the immunotherapy. So far, nivolumab has been done. 2 doses are completed. Ipilimumab, 1 dose is completed. She is due for the scan next week. Clinically doing extremely well. Because we cannot take her for surgery, we are going to continue the immunotherapy for 2 more months and then going to take her for surgery, hoping to avoid the chemotherapy subsequently. So that is where we are with the neoadjuvant in colon cancer with MSI high tumors. What do we do with the adjuvant treatment? In the adjuvant treatment, stage 2, if it's MSI high, we can pretty much avoid the chemotherapy in majority of the patients. But what about the stage 3 patients? Here, this is atomic trial which came up for publication about 2 months ago. Surgery to confirm it is stage 3. All of them are node positive, MMR deficient, close to about 712 patients or so. Randomized to normal or standard chemotherapy. Folfox is basically used in US for insurance purposes, or Kpox. For the study, it was Folfox, and then it was given along with atezolizumab, which is an immunotherapy PD-L1 inhibitor. So out of 712 patients, post DFS was about 87%, was a 76% was the chemotherapy alone. And here, one of the argument for this trial was atezolizumab is not that great an immunotherapy drug compared to the other immunotherapy drugs. Even with this, we are having almost close to 10% benefit in DFS, and hopefully it will translate into overall survival. In a year or two, we should know where we are. So now, even in the adjuvant setting, immunotherapy in MSI high patients will be used. Next, we come to the metastatic cancers. Metastatic colorectal, all of them are put together in the same sequence. Immuno or BRAF mutated, HER2-neu, VEGF and RAS mutated cancers. So MSI high, pretty much everybody knows pembrolizumab or EP plus Nivo. EP plus Nivo is considered slightly better than pembrolizumab, even though there is no head-to-head trial. And pretty much that has become the standard. So progression-free survival of exceeding 4 years if they are MSI high, compared to 6 months in a metastatic setting. So for MSI high, upfront immunotherapy, no chemotherapy at all. For the BRAF, what we have is the breakwater trial. BRAF tumors are pretty bad. Usually metastatic, you are looking at about 5 to 6 months survival. Average survival is 5 to 6 months. If they get chemotherapy and if they respond or whatever, you're looking at about 7 or 8 months. That's pretty much it. By 8th or 9th month, you can essentially call it off. So here, for the BRAF V600E disease, cetuximab, encorafenib and Folfox, 61% response rate. Still the disease is aggressive. We are looking at about 12 months to 13 months. I think this is the first trial where we have crossed more than 1 year for BRAF positive colorectal cancer. KRAS is one of the major mutations. If the KRAS is positive, cetuximab will not work. Almost about 40% of colorectal tumors will be KRAS positive. The initial one was like KRAS G12C, which is the most common out of the KRAS. Sotorasib is one of the oral tablets, along with the panitumumab. In the second line, it is approved, but the PFS is still only around 6 months. And it is very horrible to take that tablet. Standard dose is close to like a 960 milligrams, but nobody will be able to manage 960. So we end up giving only 240, which is 1/4. And it will work extremely well at 240. In US also, pretty much 240 is the kind of a dose all the practitioners will use. But you will get extra 6 to 8 months out of it. The latest one, not yet available, but we are hoping for approval by the end of this year, is onvansertib, which is used for all KRAS, all RAS mutations, KRAS, NRAS, HRAS, along with Folfox or Folfiri and Avastin upfront. This has about 65% response rate in first line compared to 30%. I think the final data is going to come out next month in Austin. If the data, that's going to be for about 2.5 years. If the data is good, probably in December, the onvansertib will be approved. If that gets approved, I think that will be probably a $20 billion drug, easily. And it is used in 20 milligrams and 10 milligrams oral tablet. And the CEO of the company is an Indian. Okay. So that's where I will stop with this. Thanks.
Thank you, sir. Any questions from the audience? Sir, I think immunotherapy is going to come a major way in the prognosis of cancer. Yes.
I think immunotherapy has changed the playing field significantly, not only in the colorectal, gastric, I mean, you name it, lung, liver, everywhere. It is there. But we just have to choose the right patient. At the end of the day, I think patient selection is the key. still looking at the patient is the important thing.
More and more people using immunotherapy. Do you think the prices will come down?
Oh, it has come down. Like if you look at pembrolizumab is 10 lakhs per year in India, and the nivolumab is also about 9 lakhs. Now you have like a tislelizumab that's approved in EU that comes to about 6 lakhs for a year's worth of dose, and dostarlimab is going to be somewhere about 8 to 9 lakhs or so, 9 lakhs I think by Glenmark, and even pembrolizumab will be losing its patency soon, so we will have more generics. But having said that, Pembro will come up with a subcutaneous injection soon. So, usually the major complication with immuno will be that we worry about. Pneumonitis can happen in about 2 to 3%. Out of the 2 to 3%, I mean about 10% of the 2 to 3% will die with pneumonitis. And the other one will be colitis, like persistent diarrhea, grade 4 diarrhea, like about 70 times and 80 times. And altered liver function. People have died with the liver function. That is about 1 in 10,000 will die because of the liver. Myocarditis is one of the things which we are realizing now. And people do die because of immune-mediated myocarditis, renal failure. The most common will be the thyroid dysfunction. That's the easiest that we can manage. It is not at all dose dependent. Most of them happen only after the third or the fourth dose, not the first 2 doses. It does help. We will stop it, and it will require steroids for treatment. And if it is immune-mediated hepatitis, it will be steroids plus mycophenolate. And then you can also use all the COVID drugs for the immune-mediated side effects. And most of them do work.
If there are no further questions, thank you, sir. Thank you so much. We'll move on to the next part of the CME.
Thank you, sir. Next, we move on to the panel discussion, Turning the Tide on Liver Cancer. First, I invite our moderator, Professor P. Basamani, Senior Consultant, Department of MG, Apollo Hospitals, to the podium. I invite the panelists, Dr. S. Arul Prakash, Senior Consultant, Department of MGA, SRM Prime Hospital. Dr. Babu Kumar, Senior Consultant, Department of Gastroenterology, Gleneagles Hospital. Dr. Suhasini, Professor, Department of Radiology, Stanley Medical College. Dr. Mahesh Sundaram, Senior Consultant, Department of Surgical Gastroenterology, Kaveri Hospital. And Dr. P. N. Satyamurthy, Professor and Head, Department of Medical Oncology, Stanley Medical College. Over to you, sir, Basamani, sir.
Aim is to make it interesting. I am circulating 10 MCQ questions to postgraduates. There is only one right answer. Yeah? So please don't consult artificial intelligence to answer. I'm relying on your honesty. Okay. We'll discuss the questions at the end. Yeah. So I have esteemed faculty. Thank you very much. First, I thank my friend Sumati for giving this offer. This disease is very close to me because now once you choose gastroenterology, you have a tryst with this disease every now and then. It comes in various forms and shapes. Sometimes you wonder whether you did harm more than good by diagnosing, indeterminate lesions, anxiety to the patient, inconclusive decisions, lack of MDT. No, but most of the time we end up doing good to the patient. And there is no single treatment, there is no single staging system. Whenever we have more than one system, that means we are far from ideal. We are still chasing the holy grail. So whatever it is an interesting condition. And we all know that it is in top 5 in India, both in occurrence and causing deaths. With the epidemic of MASLD as well as the alcohol-associated liver disease, it is all set to increase in future, even though it saw a dip in the West in the past. And it's not the cirrhosis, it's the hepatitis which is precancerous. It's a chronic hepatitis which leads to both cirrhosis and the cancer. So we can have cancer even without cirrhosis. I think even in hepatitis B, up to 20%, no, 10 to 20% of patients can have in mast-related MASH, no, we can have even pre-cirrhotic cancer. So we should understand that principle. It is the inflammation and mutation and accumulation of mutation errors that leads to cancer, and as well as the inflammation and ineffective repair that leads to cirrhosis. So, but synonym is cirrhosis is pre-cancerous, but actually it's a chronic hepatitis which is pre-cancerous. And we all are aware of risk factors. And we are all aware of the high-risk population as well. So the high-risk population is anybody with cirrhosis of any etiology. Historically, B and C have taken the bulk, but alcohol and MASH are closely competing and trying to get one. So 2%, 1%, and even 0.5% incidence per year has been taken as a threshold for application of screening the selected population. Anything less than that, now if it's 0.2%, like non-cirrhotic hepatitis B, particularly in sub-Saharan Africa, it is still acceptable for gastro community. Where we are not sure, but there is increased risk of cancer for an individual, but as an economical model, whether application of screen will be of cost effective is hepatitis C without cirrhosis, because all of us know that hepatitis C, even after SVR with cirrhosis, should be on indefinite surveillance for SCC, whereas if there is no cirrhosis and MASH without cirrhosis, we all know that they have an increased risk, but because it is less than 0.2. So we are always reactive. No, we wait for a disease to come and we are good at diagnosing and treating it. This is good for acute illnesses. No, we don't go and intervene with them. But if somebody comes with a pneumonia or a flu or something, no. So despite vaccination and all the precautions, certain conditions, especially infectious diseases, they happen and then you go and intervene. There itself with prevention has become a mantra. But in non-communicable diseases, we still have the same attitude. Let the patient develop some symptom and come to us, and then we will treat. Our attitude should change at the root level, where there is a long window of opportunity as healthcare providers. We should, and like Professor KRP sir, now taking health education to the community and prevention. So HCC, when it comes at a stage B or C, the prognosis is abysmal. So we should be more interested in prevention. So to that end, I invite Babu Kumar to, as healthcare providing community, what can we do, give back to our community to prevention? Because prevention usually is discussed last, but I am putting prevention at the first.
So basically, good evening everyone, and so basically the primary aim is to prevent patient going to cirrhosis. So that should be the primary aim in any patient with liver disease. For example, for hepatitis B, there is an universal birth dose vaccination is available. In India, in universal immunization program, and hepatitis B vaccine has been introduced in 2011 onwards. One at birth and other three dosage in 6, 10 and 14 weeks, and it's free of cost. And all patients with hepatitis B should be given antivirals, and so that patient will not progress to cirrhosis. The same applies to HCC, screen and treat, and with directly acting antivirals. And of course, alcohol abstinence and various de-addiction programs should be done at the community level and personal level as well. And the NAFLD and other metabolic diseases should be aimed at reducing the diabetes and dyslipidemia and weight loss. And other etiologies of cirrhosis, autoimmune hepatitis should be a good immunosuppression so that patient will not progress to cirrhosis. Of course, PBC with UDCA and hemochromatosis, regular phlebotomy. and Wilson's disease with the zinc. So, and other rare causes like avoiding aflatoxins by means of proper crop management with food authorities, and hepatitis A vaccination for all patients with chronic liver disease, so that patient will not develop acute on chronic liver disease. Thereby, that will prevent a long-term risk of HCC.
So Babu Kumar has one more slide. The one-line summary is: if chronic hepatocellular inflammation is precancerous, prevent it or intervene and stop it. I think that's it. For example, cofactor. No, if I have hepatitis B and if I drink, it's not 1+1. It is synergistic. Alcohol as a cofactor can increase the risk of HCC by fivefold, up to fivefold. So you should control the main factor as well as the cofactor. So that's the thing. The early detection follows the screen prevention, but prevention is much better than cure. That's a very cliche statement, but very, very relevant in our case. So next to prevention, I think very early detection makes a matter. So having identified the high risk population, it will be negligence if you do not offer the early detection tools to the patient. Patient preference is a very important decision making factor. But from our side, we should discuss with precise knowledge and exact the clinical setting. So I invite Arul to enlighten.
So to detect early HCC, we all know that we have conventional techniques, which is ultrasound, CT, and MRI, which has its own plus and minus, and serum alpha-fetoprotein. Ultrasound is a very cheap and non-invasive investigations, but the sensitivity is relatively poor when you talk about early small lesions. And you know that it's operation dependent, and maybe a sonologist, a good trained sonologist can pick up lesions with accuracy. And in obese individuals, it's difficult to pick up early small lesions. With that alpha-fetoprotein, and if you combine an ultrasound, you have a good sensitivity. So, and we should know that only 70% of HCC will have an high alpha-fetoprotein. You may miss at least 30% of the HCCs. It's very inexpensive, it's available everywhere. And combined with ultrasound, it has a good sensitivity. And you know that there are false high AFP in inflammation and in pregnancy, so you have to keep that in mind. And next best is multiphase CT, which is available better than ultrasound in detecting early lesions. And the flip side is you cannot repeat, like you cannot screen again and again with the CT because of risk of radiation and the contrast risk. And if you have a doubt in early lesions, you can go for an MRI. The problem is it's costly, and it's not available everywhere if you take as a whole, but in practice we do use it. And these are all the conventional techniques, but there are advances like say biomarkers other than alpha-fetoprotein. We have alpha-fetoprotein L3 and this PIVCA2, which is in practice, but it has its own limitations. But when you combine AFP with the PIVCA2, you have a good sensitivity. And there are newer techniques like liquid biopsy, which we had a discussion earlier, where you make out circulating tumor DNAs and mRNA panels and exosomal markers, which can pick up early lesions when you have a difficulty in imaging. And coming to imaging, there is a contrast enhanced EUS. I don't know how good, radiology colleagues are.
Suhasini will come to.
So it's better for, it's in real time and better for small lesions, and you know that technical feasibility of and learning curve is there. And there are newer AI enhanced imaging and risk stratifications where the imaging itself, the AI can understand and probably help the physician. There are studies to state that AI is better than a physician in diagnosing HCCs, but as of now, it's not into practice. As time goes, probably we'll have better help from AI.
This panel discussion came at a right time. No, so Sumati ma'am set the setting. How important this cancer is about the study, and the journal scan showed the hypermethylation, where we are still looking for markers to improve the diagnosis, especially early ones. And also the GA oncology, even though colorectal cancer, no, we talked about molecular diagnosis and targeted therapy. So all the setting is there. So now, so there are very few cancers in clinical practice where a clinician and oncologist will talk to the patient as a relative who got cancer without a tissue diagnosis. Even though liver biopsy is now coming of age for various reasons, including for molecular markers, the current clinical practice is if we have a good reporting system, a definitive HCC, especially in the background of cirrhosis, hepatitis B, and previous hepatocellular cancer, in these three settings, it is still an imaging diagnosis. So I invite Suhasini here to take over and then educate us about all the nuances of HCC as well as the mimics and how to wade through them.
At the outset, I would like to thank the medical gastroenterology team at Stanley Medical College for giving me the opportunity to address this elite gathering, which includes all the directors and including the Dean of Stanley Medical College. Thank you, ma'am, once again. So basically the diagnosis of, sir, it's not moving, sir, next slide. So why imaging is important is, as you all know, until recently it is said that the diagnosis of HCC has to be only imaging based, because if we do a biopsy, we are likely to seed the peritoneum. Therefore, imaging has to have a good degree of accuracy to give whether the possibility of the lesion that is under our eye is HCC or not. So that is the question to be answered. So very simple regarding imaging is if we understand this one slide. Because we know that liver has got dual blood supply, which is mostly from the portal vein and very little from the hepatic artery. But once the liver is replaced by the tumor cells, what happens is these tumor cells prefer to get the blood supply from the hepatic artery and not from the portal vein. That one knowledge will help us to identify whether the lesion that is there in the liver is a malignant lesion or not, okay, provided that it is a hypervascular lesion. So that is the basic knowledge on which we are going to time our triple phase CT. So what is this triple phase CT? I will explain it slightly in the further slides. Basically, it includes a non-contrast scan, a late arterial phase, a late portal phase, and an equilibrium phase, which has got different timings. It's enough if we remember the 35 seconds, 75 seconds, and the 5 minutes. So those are the timings that we will be using. So to understand how the various nodules will be seen on these scans, we know that regenerative nodules are basically hepatocytes trying to grow in between the fibrosis of the cirrhosis. Therefore, the regenerative nodules will resemble the hepatocytes in all the phases. Dysplastic nodules, whereas they are in between regenerative nodules and they are undergoing dysplasia to become a HCC, but they are not full-blown HCCs yet. So initially in the plain T1 weighted MRIs, they will appear bright because of accumulation of blood products, some metallic contents like copper, etc. But then in the arterial phase imaging, they have not yet earned that much of hepatic artery supply. So they will not be very bright on arterial phase images, and there will not be much washout also because not much neoangiogenesis has happened there. So dysplastic is, it's bright on T1 and also some amount of enhancement, but it is not showing a good washout. So that is a dysplastic which is on the way to becoming a malignancy. So we'll just skip it, we'll understand the basics, then we can identify. So I told you the various phases. One is the plain, then we go to the arterial. There is basically the early arterial and the late arterial. Early arterial is just like doing an angiogram. That is needed only if we are planning TACE, otherwise we can skip that. And then go to the late arterial phase, just remember 35 seconds. And that late arterial phase is the workhorse for picking up a hepatocellular carcinoma, because in that phase, most of the tumor cells are taking up the contrast and they will appear very bright like a light bulb. And the liver has not yet taken up the contrast because liver waits for the portal phase to take up the contrast. So late arterial phase at 35 seconds will help us to pick up this hypervascular HCC. And then we have something called the portal venous phase. In the portal venous phase, at 70 seconds, the entire liver is now getting its blood supply. At this time, the hepatocellular carcinoma will either be equal to the liver or if it has got enough neoangiogenesis, it will already be washed out and it will appear less than the surrounding normal liver. So that's how we know that this is a hypervascular HCC sitting there. And then we have something called the delayed phase, that is more for picking up the peripheral fibrotic capsule of the tumor, because that one, it slowly, the contrast enters the fibrotic capsule, the tumor has washed off all its contrast, but then the peripheral capsule will light up in this delayed phase. So we'll see images for all that. So the take home is 35 seconds for the late arterial and 70 to 75 for the late portal venous phase. So as sir already said, USG will be a good screening, that it will show us the direction that something like a mass is sitting there in the liver, and also it is very useful for picking up the tumor in the vein. The portal vein especially, whether it's a bland thrombus or tumor thrombus, can easily be picked up because a tumor thrombus will show vascularity within it. Of course, liver has got a challenge that it is sitting under the dome of the diaphragm and it has got lung all around it. So the patient has to really take a deep breath for us to at least get more than half of the liver under our vision. So CT is very useful. We will see that again. CT, MRI, and basically when it comes to contrast, CT and MRI, the contrast characteristics of the tumor are almost the same. So here we have a tumor, which, how do I know it's an arterial phase? Just look at the aorta, it's very bright. So that's the arterial phase, and in this you can see so many vascular channels inside, and the tumor has really lit up and the liver is not yet bright. And then you have the portal venous phase, where you have the portal venous radicals filling up. The aorta is not so bright. The tumor is already washed out. It is slightly less bright than the surrounding liver. And now you have this delayed phase at 5 minutes, where you can see that the capsule is lighting up, but the tumor does not have much contrast in it, which is already washed off because of the neovascularity inside. So this is an ultrasound image just showing us that there is a mass sitting there which needs further evaluation. With regards to contrast enhanced ultrasound, first of all, the contrast is costly, and secondly, it has to be done within that moment, and then the images have to be stored and then viewed again and again. So it's all in the timing. If we miss the contrast in that first 1 or 2 cycles that it goes through the liver, then we will miss the characterization of the lesion, and the vials are quite costly. So it's always better to go, but they are very safe as of date. So in case we don't have a chance to do the CT or the MRI, only then ultrasound contrast comes into play. But the mechanism of enhancement, everything is the same as we are seeing now. So now this is an MRI image where this is T1 weighted image. You see the tumor is bright because it has got some metallic particles, blood products, fat, everything is bright on T1. This is a fat suppressed image to show that it is still bright. So the brightness is not only due to fat but also due to the blood and metallic products. This is an arterial phase where the tumor is lighting up. Here too, same rule. The aorta is bright, the tumor is bright. Then you have the portal venous phase, aorta is not so bright, tumor is already beginning to wash out. And this is a late delayed phase where you can see the contrast already coming out of the kidneys, and there is a thin peripheral rim that is lighting up. So CT, MRI contrast basics are the same. How we interpret is only based on what image is given to us. But we just have to make sure that the timing has been perfect. So this is another image showing us all the neovascularization inside the tumor. This is a metastasis in the same patient. Again, this is to show the tumor in the vein. We see the vein that is distended here, but no contrast has been taken. You can see contrast everywhere else. And you can see another patient with a tumor and a vein which is lighting up similar to the tumor with all the similar kind of vascularity. So to find out whether a particular tumor with a thrombus is bland or tumor thrombus, we have this A-vena criteria where first we correlate with the serum AFP levels, whether the vein is distended or not, whether it is enhancing with contrast, presence of neovascularity, the thread and streak sign, and finally whether the thrombus is actually leading to the adjacent mass. A criteria, point of 3 out of 5 will tell us that the thrombus that we are seeing is probably a tumor thrombus. But the best one to tell us 100% with surety is whether the thrombus is enhancing, especially with new blood vessels seen inside. So extrahepatic metastasis, we can see here all the common ones, but we'll skip because this will anyway be seen clearly in imaging. PET-CT in HCC is actually not very useful because a well-differentiated tumor will behave just like the hepatic cells around, and it will also metabolize the FDG in the same way. Therefore, in a well-differentiated tumor, PET-CT is not useful when we use FDG. And this poorly differentiated tumor is not going to have the same kind of enzymes, and therefore that can be picked up with a PET CT, 18F FDG PET CT. So now coming to LIREDS. LIREDS is actually a big topic in itself. I will just throw a little light on it. So LIREDS can only be applied if in an adult patient over 18 years old, if there is cirrhosis or there is a chronic liver disease with chronic hepatitis B, or patient has been prior treated for HCC. So this also includes transplant patients, but it should not be applied to patients who have cirrhosis due to some other vascular causes. Why? Because if there has been a Budd-Chiari or a tumor, thrombus like extrahepatic portal vein obstruction, that itself will cause a lot of vascular variations in the liver parenchyma, and that will intervene with our interpretation of what we are going to see in LIREDS, because the basis of this is only give contrast, see if there is a good arterial phase enhancement, see if there is a good washout, look for the capsule, what is the size, has the size increased substantially to 50% or more within the 6 months of follow-up. That is what we are going to see. So it's all going to be about the enhancement that we just saw. So whenever we take an image and interpret, this is the table that we are supposed to have. We need not by heart it or get memorize it. All we have to do is interpret the images, apply the table that is here, see if the tumor, what is the size of the lesion, does it have arterial phase enhancement, does it have a good washout, is there a capsule seen in the delayed images, then find out in which table this category of this where it fits, and based on that the LR category is given for the lesion. So what is threshold growth? Like I told you, it's an increase in size of more than 50% in less than 6 months. So ancillary features are there, which are nodule and nodule, that is within a sidrotic nodule, malignancy is coming, mosaic kind of perfusion, fat within the lesion, blood products within the lesion. If all these are present, it means that the likelihood of the lesion that we are seeing is more likely to be HCC. So this will help us to upgrade or downgrade the tumor between the LR categories, but never to LR5 from LR4, because these are not absolute features of HCC. So between LR3 and 4, this can be used. So as the LR categorization increases, the chances that the lesion that we see is malignant is very high, be it HCC or some other malignancy. So this contrast enhancement characteristic is very important for us to decide whether the lesion that is in the liver is malignant or not, and what are the chances that this lesion is a HCC. So tumor response assessment also in the present day, I even discussed with the radiologist from RELA. What they said is they are following the LR-TR response because that is most useful. It doesn't only take into account the size, because HCC normally doesn't reduce in size after treatment. So size may be misleading into you thinking that the tumor is still viable. Whereas if we use the LR-TR response, where again they apply the same rule that whether there is a contrast enhancement, whether there is washout. This will help to tell us whether the lesion that we are seeing, whether it is having viable cells or not. So, but for all these, the image should be of good quality and of a proper timing. Only if that is acceptable, then this LR rules are applied. So what are the close mimics? What we have, one of the close mimics is fibrolamellar carcinoma, which has got a scar in the center. Once we talk of a mass with a scar, FLC and FNH are the ones that come to our mind. One thing to take home is FLC has got a true scar. FNH is a vascular tumor, therefore it has got a vascular scar. That's it. So when it is a true scar, how much ever contrast you give, how much ever you wait, it's not going to take up the contrast. So even in delayed images, if the contrast is not taken up by the scar, then it is an FLC. But if in the delayed images the scar takes up the contrast, then it is an FNH. That is the simple thing. Of course, there are always exceptions in medicine. Only 70% of the tumors will follow this rule. The remaining 30% left to you to further work up. And that is where the hepatobiliary agents in MRI come into place, where they are taken up by the FNH but not by the FLC. So these are the various differentials. I'll skip them for want of time. So this is another tumor where you have a central scar that is taking up contrast. So simple, that is an FNH. So this is an adenoma where you have a tumor with a smooth margin and already bleed inside. History is very important in this patient. And here it does take up contrast but not as bright as the aorta, and there is no significant washout either. So interventions, various interventions of giving chemotherapeutic agents or radio therapeutic agents are available, and also radio frequency ablation and microwave ablation. So this is another closed DD where we have a tumor that is taking up contrast but not so well as the HCC. And another important clue is that the surface of the liver has already drawn in. This means that this tumor has got desmoplastic reaction going on in it, and such a tumor in the liver can only be a cholangiocarcinoma. So one thing is, when we see cholangiocarcinoma, when we see the mixed type, the hepatocellular carcinoma and the cholangiocarcinoma, the doubt comes when the imaging features are that of HCC, but the tumor marker is that of cholangiocarcinoma. In such a scenario, we know that both are existing within the same tumor. So this is another HCC we've already seen. There is lighting up in the arterial phase, washout, and this is the washout, and this is the fibrous capsule around it. This is a mimic, which is a huge hemangioma, but the one clue is there is peripheral enhancement always equal to the vessel in that sequence. See, this vessel is only this bright, the enhancement is only equal to that. Here you can see the aorta is very bright and the enhancement in the periphery is equal to that of the aorta. It always lights up from periphery and towards the center as we take the delayed images. So this is another example of a hemangioma. As you can see, periphery is bright, equal to the aorta. Another cholangiocarcinoma, the surface pulling in and not much of enhancement are both clues that some fibrous reaction is going on inside. This is a tumor which is picking up good contrast, also showing out some amount of washout, not fully, but this is not a HCC. This is a carcinoid tumor because it does not follow the typical features of a HCC. We know it is an LRM, not a HCC. So this is a hepatic adenoma. We've already seen one. FNH, you can see that the scar is lighting up. So now I hope I have done my job if I've brought to your mind the enhancement characteristics and the nature of the scar and some idea about the Lyden's category. Thank you very much, sir.
So all five of us put only 43 slides. Suhasini herself brought 44 slides. So that's the art of image, you know. So she talked through within 10 minutes, I think. What's the time now? So it has not come of age for two reasons. One is the contrast itself is costly. Two, it is still very much operator dependent. And three, if you miss the window, then the sky will burst. So expertise, like intestinal ultrasound, we need a lot of expertise available. So local expertise, I don't think we do have local expertise. Suhasini, do you have anybody in the city? Like we talk about MR elastography, but we don't have the protocol and the expertise.
I think only data memory does it as well. You don't get the information other than viewers. Yeah, I want to know more about it. Because we say first line, but see the second line will be is the component. That is go you put that.
Yes, sir, like imaging is always under the probe. CD means you can run the CD throughout the whole body. But in spite of giving a contrast only all the study we can do because probe can be kept only that. We can't move the probe like the CT can be done. So whichever contrast you do, whatever you are focusing on, only that information you get. Nothing else, and that also again we were half covered. First run, second run, within that you have to finish the study. All it is not automated. It's still dependent on humans, so it will take some time.
The only thing is, it can be, if you have the expertise and the cost, it can be repeated, and quite safe with no contraindications of CT and MRI disadvantages. So it can. So, but there is no doubt that screening helps. We have multiple studies that cancers detected by screening, in spite of lead time bias, length time bias, and residual bias, and all those things, confounding all the confounding biases, I think there is a consensus among our medical community that screening helps. But as I alluded in the beginning, it is a very, very, very individual decision. So this is where the individual case-to-by-case decision about screening and the MDT decision about what we find in screening, algorithm, once the ultrasound comes with a finding, how do we go about it is very much individualized. So this is where our TNM staging and everything is leaving you high and dry. And hepatocellular cancer is interesting because there is no other cancer which demands a complicated classification or staging. And to tell us more about that, I invite Babu.
So traditionally, we all came across Okuda classification, which mainly focus on very few liver functions like albumin, ascites, and tumor size. And it is very too crude, and it's 1985, so it doesn't have any prognostic accuracy. So it's nobody is using it. Of course, then Milan came, revolutionized the transplant setting where you know. It gives a criteria which patients goes for transplant, which patient doesn't. But the problem is it's overly restrictive, and it excludes good biology cases. And then comes a clip which adds portal vein thrombosis along with AFB, but it's very complex. And of course, BCLC in 1999, and now with Inacel BCLC in 2023. Which incorporates, it's a stage-based treatment, but again it is rigid and it is not individualized. If you take BCLC of stage B and C, that itself has got various heterogeneity. So that has not been represented well with this staging. And of course, newer Asian stagings are coming up, which includes Kyoto, Kyushu, and Moral and Snap. So basically, these are all being developed by a South Korean group that includes combined biology and morphology, which is complex scoring, which has got limited use. Next slide. So basically, why we need staging for HCC? Majority of the staging system, including BCLC and other things, doesn't include biomarkers, which is basically an AFP and now with the PIVCA. For example, AFP negative tumors are very aggressive. AFP more than 1,000 carries a risk of post-transplant recurrence. So does applicable to PIVCA as well, and of course neutrophil lymphocyte ratio. So beyond morphology, no staging system addresses the current staging system. And of course, dynamic evaluation. You do a local regional therapy, you give the patient ablation or a TACE, and subsequently, are we assessing whether the patient has got a AFP which initially was 1,000, now it has got reduced to 400, which indicates the tumor is responding well. So that dynamic evaluation not been addressed in the current clinical system that we are facing now. And a personalized prognosis, differentiate high versus local low risk tumors. And which tumor adapt to immunotherapy, that has not been addressed. So basically we require a integrated system which includes not only the tumor size, which also should include the tumor morphology and biology, so that a lot of immunotherapies are coming up. So we often discuss about cold tumors and hot tumors. Now we are marching towards mRNA-based therapies, personalized cancerized therapies. All those things are coming in future. So we require any comprehensive staging which incorporates all the three. So I think that would be the unique staging which is yet to develop.
So that's a beautiful. Thank you, Babu. The SCC is interesting. I told you, a cancer accumulating fat. Don't you think it is an odd behavior? Of all the things, it is accumulating fat. And Shankar will agree. Within the tumor, there is an environment of immunosuppression. It's not bothered about rest of the body. There is a immunosuppressed state within the tumor. So the bottom line is, it is far from ideal classification system, including the local system that we have. We still need something that will fit a clinical purpose, and it is dynamic. There is something called downstaging, and there is something called stage migration. While you are waiting, a patient can move from B to C. So that it's a dynamic staging. And equal plethora is the guidelines. We have guidelines from our one INASL, we call them recommendations, as well as from rest of the world. Arul, can you throw some light on the gist of these guidelines and what should our postgraduates take home with them? Yeah.
Yes, sure, sir. There are around 13 guidelines which are available in the literature for HCC management, and So we have our own INSL Puri recommendation based on BCLC, and you have list of American, European guidelines, Asian, Japan, and you have other Asian countries as well, and you have European and British Society of Guidelines. So what is the common thing across these guidelines is what we have to do for surveillance. Those, you don't need to stick to the guidelines. You can understand and practice according to your local availability. The cheapest one is an ultrasound and AFP every 6 months for serotics, just for surveillance. So they all given recommendation for surveillance. For diagnosis, the best is multiphase CT or an MRI. And for staging, though we have lot of these available methods, techniques, BCLC is more practical. And we have to include liver function and the performance status of the patient. So for therapy, you have curative intent therapies like resection, transplant, or ablation in early HCCs. And for an intermediate stage, you have TACE, TARE, or an SBRT. And with the availability of local resources, you can change your algorithm. So, it's not very rigid, and you have to practice based on your patient condition and the local available resources.
As well as cost, because in United States, TAR has become a standard of care compared to TACE, but in Asia and we still offer TACE or even plain TAE, TAE as a first line therapy. So that takes us to our basic template, which is BCLC, but it is too rigid and it does not account for heterogeneity of this intermediate stage, which Satyamurthy will discuss at length, as well as the availability of multiple treatments, including radiotherapy. So when one arterial intervention is contraindicated because of the venous thrombus, or one ablation is contraindicated because of the location near diaphragm or heat sink effect, we can always go to the next available best option, and sometimes they are positioned at the same level. You choose as per the expertise as well as the feasibility, and so very quite rightly, our own experts, Indian experts, modified the BCLC to suit our country. I think I will encourage all postgraduates to read this. It's available freely online. It's a 2023 Puri recommendations following the 5 years prior guidance, and they give allowance for stages, even early stage, A1 and A2, as well as intermediate stage, they divide into 3, and then even at the last stage, advanced stage, some of them may qualify for liver transplantation. So these are very important modifications that have been given to us to offer the best way of treating these patients. So now I invite my guy, because it's a field effect, so you kill one tumor with a microwave, but you are waiting for something else come for. So one stop shop is a liver transplant. Like prevention, I am going for liver transplantation as the first treatment to be discussed.
Good evening, everyone. So if you look at the BCLC or the INASL classification, the liver transplant seems to be the first branch out point. Rightly so, because most of the HCCs we see in cirrhotic patients, and the liver transplant potentially cures both the HCC and the chronic liver disease. Anybody with cirrhosis has a field effect of developing cancers in the rest of the liver as well. So this addresses it by removing the native liver. Now, certain patients are considered suitable when they are having child B or C cirrhosis, unresectable tumors. Single tumor more than 2 centimeters with significant portal hypertension or elevated bilirubin. When there are multiple, up to 3, and all should be less than 3 centimeters. So when they tried to transplant patients beyond this, they found a lot of recurrence. So they have limited the cancers which can be transplanted. So patients who have multinodular, this was not there earlier. Now you can see this in the INASL Puri recommendation also. Multinodular tumors, they come under the extended liver transplant criteria. We usually limit it for a size less than 5 centimeter and AFP value of less than 1000. Liver transplant is contraindicated just like other cancers when there is extrahepatic cancer, portal vein thrombosis. However, this is considered a relative contraindication. If you see the BCLC, this would be a contraindication, but if you take our own classification, the INASIL one, there is still a role for patients with portal vein thrombosis, especially when they have peripheral thrombosis away from the hilum, just very close to the tumor. Patients who are having poor performance status and those with high risk comorbid diseases. All these are standard for any surgery. Next slide. Okay, so all of us would be knowing about the Milan criteria and UCSF. These are basically used for enlistment so that organs can be allotted in countries where a lot of cadaver transplants are going on. In India, the situation is reversed. Living donor liver transplant happens much more commonly, and hence the waiting list problems are avoided. So during the waiting list period, some of the tumors do advance and they do need some bridging therapy so that the tumor doesn't grow beyond the criteria. For example, ablative methods like microwave, radio frequency or TACE are being used to control the tumor while the patient is awaiting transplant, because the waiting list time could be longer. Even in LDLT, arranging the finances could take time and there may be a role for bridging the therapy. So during the waiting period, sometimes what happens is biology manifests itself. So the tumor may advance despite whatever maximum treatment we give. So we do select out the patients who are advancing. We exclude them from transplant. So what happens when patients are outside the standard criteria? We have given some standard criteria. Let's take the Milan criteria, for example. A single tumor less than 5 centimeter or multiple tumors, up to 3 tumors, but all should be less than 3 centimeters. The 4-year survival has been found out to be about 74%. This is the same as the survival for a patient without any cancer. So transplant with cancer, even for a patient without any cancer, liver transplant has the same result. So if we select the patient properly, we can give good result with the help of liver transplantation.
Babu, so you know how early you catch matters, isn't it? So you have a patient with a very early stage 0 or stage A cancer. So the patient is sitting in front of, what do you tell the person?
First, I will assess whether he is a candidate for a liver transplant. If not, then I will tell them about ablation therapy, radiofrequency ablation. So I'm going to counsel him that how the radiofrequency ablation has been done, and I'm going to tell him that results are as comparable as that of resection, and only to that we need to have a good margin of 1 centimeter ablation. And then I will also tell them that a patient has to go for a follow-up scan after 4 weeks and then to assess the response. And
so stage A?
And BCLC, again, single tumor more than 2 centimeter to less than 3 nodules of 3 centimeter with a preserved function. Again, I will be assessing whether the patient is having a portal hypertension by doing an HVPG. If it is more than 10, and patient is having a bilirubin of more than 2, I will, if there is a suitable candidate, then I will advise him LDLT. And if there is no portal hypertension and the bilirubin is less than 2, then I will suggest resection.
I think up to this stage it's a little bit clear, no, what you do. No, you are more optimistic in your counseling with the patient, and even though Magesh said, no, AFP of more than 100,000, even if it's more than 1,000, no, if you bring down the AFP with therapy, no, to less than 1,000 or less than 500, then they qualify. So, like I said, it's a dynamic thing, but it all looks much better for stage 0 and stage A patients. So resection has played a great part before microwave and RFA kicked in. So Magesh, in this era of loco-regional therapy with ablation and various choices, where do you posit liver resection, minimally invasive resection and major resection, and what should our postgraduates take home to counsel the patients next time?
Yes, sir. So, one should always remember surgical treatment gives the best long term survival for HCC at 5 years. So, unfortunately, 85% of them remain ineligible either because of the tumor burden or because of the advanced liver dysfunction itself. So, the ideal candidate for liver resection should not have any liver dysfunction. There should be no portal hypertension, no major vascular invasion like the main portal vein invasion, limited tumor burden, and there should be no metastasis. If you take the non-cirrhotic patients, they will tolerate major resections. I will come to that in the next slide also. Resectability is a subjective concept. So, individual surgical expertise might vary, hence algorithms also differ from country to country and within country amongst various centers also. The perioperative mortality is very impressive. It's only nowadays around 1%, and 5-year survival ranges anywhere from 40 to 70%. Unfortunately, recurrence is common. That is why the first branching point is always, is the patient eligible for transplant? Then we go into the transplant pathway. Now, resection, well, transplant cannot be offered to every patient. Resection may be anatomical or non-anatomical. Anatomical means we go along the planes defined by the hepatic vein, portal vein and the artery. So, non-anatomical means just like a wide local excision. Those are more suitable for peripheral tumors. One should also understand what are the terminologies of the anatomic liver resection, which is segmental liver resection. All of us know about the Couinard's liver segments. Accordingly, if we resect, say, only segment 6, that is segment 6 monosegmentectomy. If we remove one half of the liver, say for example the right, that is called right hemihepatectomy. Extended hepatectomy means, for example, for the right side, if we go on to the segment 4 also along with 5, 6, 7, 8, then that becomes a right extended hepatectomy. So, in a cirrhotic patients, we cannot do major liver resections. So, for example, a child A patient, maximum up to 50% of the liver can be resected. Beyond that, cannot be resected. Otherwise, the remaining liver will fail and patient might die. So, there are several methods to do it. One can do it by open method, which is the most common being done all over. There are several indications for laparoscopic liver resections, especially the peripheral tumors, segment 2, 3 tumors. And robotic is also coming in a big way in liver resections. So, the remnant liver which we leave behind after resection matters a lot. As I said earlier, if it is a non-cirrhotic patient, this is of a lesser consequence because we can leave only 25% of the liver, remaining 75% we can remove, and still the patient will do well after surgery. Now, there are several methods to assess how much liver is remaining. One is based on CT scan. We can find out what is the future liver remnant. The other is doing a test called the ICG retention at around 15 minutes. ICG is a dye. If the liver retains a lot of ICG, that means it's not functioning that well. So it should be less than 10% to undergo any liver resection. It was not available in India earlier. Now it is available. When even for a normal non-cirrhotic patient, if the future liver remnant is going to be less than 25%, we can use adjuncts like the portal vein embolization. So if we embolize the portal vein leading to the tumor site, the opposite side hypertrophies. It takes about 4 weeks for it to happen, and it will give an additional volume anywhere from 15 to 20%. So that might help the patient undergo a liver resection. Smaller segmental resections might help because we are doing a liver parenchyma sparing surgeries. So patient may be able to withstand the surgery better. And non-anatomical resections, as I said, instead of anatomical liver resections.
So now you understand the multidisciplinary team. No, we may not have a physical MDT, but you pick the phone or you should have, now that the Zoom platform is there, I think every big hospital dealing with hepatocellular cancer should have, at least fortnightly Zoom meeting where you list all these patients. If somebody has a child A, no significant portal hypertension and functional reserve volume is at least 20-25%. Then the option of resection should be offered, which I don't think is happening, Even you said it's only 15% of patient will qualify, but do you get to resect all those?
Actually, not much, sir.
Not much, yeah.
Because now transplant has come in. So another thing is lack of knowledge also, because people.
And that's the purpose of this is continuing medical education session. Yeah. Okay. So let's take a break with the postgraduates. No. So if I'm worried about sealing the track for biopsying a liver lesion like LERADS M, no, I should do biopsy. No. So I will use a coaxial needle if available. So what is coaxial needle biopsy? Anybody? Sir, chocolate. What is coaxial needle biopsy? Only postgraduates. Even a wrong answer, you will get chocolate. I got 50. I need to get rid of them. No. So coaxial is you use a outer needle to provide the direction to the lesion, and then you use an inner needle to take the sample, and the inner needle will come out through the outer needle. So you reduce the risk of seeding the track. So who uses a C-arm CT scan? Anybody? Or who uses a C-arm CT scan? So only interventional radiologists. No, they need to get a 3-dimensional image of the lesion so that they can calculate exactly how they are going to intervene. So interventional radiologists will use it's a combination of real-time C-arm as well as a planar CT. So to construct a 3-dimensional live image to precisely deliver the intervention, local renal therapy. So so advanced is easy. Poor performance status, advanced liver disease, that is easy. Early stage, we need to improve how to reach the MDT best decision for the patient. But the most difficult part for both the clinical team as well as the patient is the intermediate. So I got the most able person to talk us through. Satyamurthy.
Good evening. BCLC staging is, as already discussed, it is very strict. But stage B, that is intermediate stage, it is a heterogeneous one. Patient having a multinodular lesions and the preserved liver function and performance status is the basic qualification. So modified BCLC as per the Indian criteria, we divided into B1, B2, B3. B1 is the patient can be accommodated for transplant by using extended liver transplant criteria suggested by the various group. So Milan, they strictly the criteria is less than 5 centimeter size and number of nodules 3 up to 3 and with 3 centimeter. But extended group, they increase the size to 6.5 centimeter.
You want to come in?
Yes. So extended group, they suggested the size will be up to 6.5. Some group suggested is more than even 7 centimeter, up to 7 centimeter criteria. And number of nodules will be 5. Total number will be included into the totally 8 centimeter also is included in the extended criteria. If you fit into the B1 category, the patient can be taken up for transplant. B2 is, again, it is this is the University of California and San Francisco definitions. The single size is up to 6.5 centimeter or 3 nodules with less than 4.5 centimeter. Here also the overall survival outcome is more than 5-year survival is more than 70% as equal to the Milan criteria. So B2 is a multinodular which is not fit into the B1 criteria, but you can use TACE for downstaging the disease. There is a data for downstaging, is possible to downstage or not. This paper published by the Bharat in the liver transplant journal, he taken up for downstaging for B2 for 516 patient. They used the TACE for 230 patients. This can be converted for transplant for 87 patients. Up to 38% can be converted to the transplant by using TACE. And by using TAR, 17% patient can be converted into the transplant group. So B2 stage can be converted, downstaged by the liver directed therapy, and it should be fit for transplant. B3 is preserved liver function, but multicentric, extensive, and infiltrative tumors which cannot be fit for TACE or transplant. This can be converted into the systemic disease. That's why the intermediate stage is very heterogeneous. We need a multidisciplinary team to decide what to be done. So intermediate stage, lot of trials are many groups tried various trials in the intermediate stage. They used TKI, TACE plus TKI, and TACE plus immunotherapy, and IO therapy plus TKH plus TACE, but none of them has proved the overall survival. Yes. So this is management of advanced stage. The patients are performance status 1 or 2, and some compromised liver dysfunctions like Child-Pugh B or C, and extrahepatic disease is coming under the advanced stage. Most of our patients are present with advanced stage only. So only systemic therapy is the option. Before 2007, chemotherapy was tried, various chemotherapies were tried before the sorafenib established the standard of care, like cisplatin, 5-FU, gemcitabine, and doxorubicin, and Folfox regimens are tried, but they produce only toxicity, there is no survival benefit. In 2007, understanding of the pathways of hepatocellular carcinoma, multi-kinase inhibitors are coming in the major way for treatment. Sorafenib is the gold standard from 2007 onwards, which gives survival of 10 months to 13.7 months is the maximum survival till 2007. After this, multiple drugs are tried, sunitinib tried, and other drugs, regorafenib tried, but nothing is proved superior to the sorafenib. Then lenvatinib is the standard of care. Lenvatinib is non-inferior to the sorafenib, but the overall response rate is superior to the sorafenib. That's why now the first line will use lenvatinib instead of sorafenib. In 2020 onwards, it is an immunotherapy era. The trial, IM Brave trial, which is the results are published, which shows atezolizumab with bevacizumab, which gives, comparing with sorafenib, the survival rate is more. Sorafenib gives only 13 months. Till now, the maximum survival is given by the atezolizumab with bevacizumab, that is 19 months. So NCCN and other guidelines, atezolizumab with bevacizumab combination is the first category 1 recommendations. Next, the Himalaya trial results are came, where durvalumab with tremelimumab was used. It also gives survival of 16 months. These are coming under the category 1 recommendation now. But practically, these drugs are very costly. We have to spend in lakhs. As only monopoly is there. Indian biosimilars yet to come to treat the cases. Till now, we follow lenvatinib or sorafenib. Our survival is up to what we advanced stage is only 13 months. If patient progressed on lenvatinib or sorafenib, other options we have regorafenib, which is cheaper, and cabazantinib, and some patients may get ramucirumab is another monoclonal antibody against VEGF inhibitor. The subgroup analysis shows if AFB is more than 400, ramucirumab has a survival benefit after the progression of the TKAs. This is practically we are using. We didn't have an experience with IO therapy. Just I want to request our senior consultant Sankar sir may experience with immunotherapies. So you want to add some real world experience. TK, immunotherapies.
Pretty much, I think our go-to was almost like desolizumab and bevacizumab. Having said that, we were part of the Himalaya trial. Apollo, I think we had 7 patients enrolled on the global trial, and we have, in addition to the trial, we have used it in about 7-8 patients now. Those who are ineligible because of the various reasons, and so far the response rates, what I have seen about the 20-25 patients with immunotherapies, almost about 60% response rate we've been seeing, and we have patients going on for like year number 4 also with immunotherapy combinations. I mean, those who can afford it has been going in. Some of the insurances do cover it. If your insurance cover is like more than 50 lakhs, or ideally if it is 1C, immunotherapies, all the transplants, consumables, everything will be covered without any questions. So if at all, this is mainly for the younger ones as well as older ones, please do take the insurance with the highest cover when you are healthy. Do not wait until you get sick.
I think that's the most important point of today's CME, I think. Yeah. Thank you, Satya. Please take your seat. So now I, with my deep felt gratitude to the panel and the Professor Sumati and for the patient audience, I am bringing this discussion to conclusion. I think you are convinced that we are really changing the tide of HCC where it was abysmal and poor prognosis. You all agree that it's a very interesting, challenging, if not a very complex cancer to learn. So it is very special. No patient performance status, tumor burden, liver status, everything comes to staging, and it is dynamic and ever changing. Many options with overlap and equally positioned, and guidelines may confuse you rather than provide clarity if you go to them. More and more, I think we will be needing biopsy to guide us the personalized therapy. Prevention is the key. Early detection is the best thing. If I am destined to get cancer, I would like to get detected early. So whenever possible, feasible, liver transplantation should be the treatment of choice because it removes the complete portal hypertension, everything. So, but in the select patients with no portal hypertension and child A and early child B of 7, then we can talk about resection. And there are people who cannot qualify for resection. There are excellent local regional ablative therapies, including microwave, available in many of our own hospitals. And whenever it is intermediate stage, it can be downstage or it can progress over the other stage. So beware of the waiting period and what is the best way to manage these patients. For advanced therapy, I think in 2 years' time, many of the therapy would have been superseded and we will have much better targeted therapies. So thank you very much for your attention. I will request postgraduates to come to me with their answers, and I will distribute chocolates without wasting time. Others can go for meal, but postgraduates can come after vote of thanks too. Thank you. Thank you very much. Thank you.
Congratulate Dr. Sumati Madam for organizing this GI oncology session, and Dr. Shankar Subramaniam sir, and Dr. Basamani sir, and the panelists for an excellent discussion and multidisciplinary approach on HCC. Thank you, sir.
Thank you. Thank you.
So, panelists and chairpersons for the wonderful meeting here. So, it's a time for vote of thanks. I'd like to invite our patron to felicitate our guest doctors from other specialty. I'd like to invite Dr. Shankar Subramanian. Shankar Srinivasan, yeah, please. Dr. Niranjan. Dr. Satyamurthy. Dr. Suhasini, madam. Dr. Mahesh Sundaram, please. And English.
Lights. There were a couple of postgraduates whom I missed out. I would like to congratulate Dr. Tirupati Venkatasai Vaibhav and Dr. Rajat Prabhakar Pandey, who were awarded the first and the third prize, post of distinction in the INSL, recently concluded INSL meeting. So I think a big round of applause to both of them. The first and the third prize in a national level meeting is something wonderful, remarkable. So to Dr. Rajat and Dr. Tirupati Sai Vaibhav. And I'd request Dr. Ratnaswamy to come over and invite you for this forthcoming meeting, please. And with that.
Good evening. Thanks for the opportunity. The Tamilnadu Surgical Gastroenterology Association is conducting the IASGCon 2025 in October. I take this opportunity to welcome you. You had a very good discussion today on GI oncology. You can have much more information with this conference. This is the base of this GI oncology innovations AI. I welcome you all, and especially postgraduates. Thank you.
Thank you, sir. And I thank all of you. Please join us for dinner. It's already ready. Thank you.